So good morning, everyone. Good morning, distinguished guests, respected faculty, and dear doctors. So it's my great honor to welcome you all to Ajanta's ACME 2025, a celebration of scientific collaboration, learning, and innovation in medical education, with a special focus on the ever-evolving fields of cardiovascular and diabetic therapy. It's truly inspiring to see so many dedicated professionals here, united by a shared commitment to improving patients' care and advancing medical knowledge. ACME has grown into a vibrant platform where science meets education and ideas transform into clinical excellence. These years' focus reflects two of the most pressing health challenges of our time: cardiovascular disease and diabetes. Conditions that not only share pathophysiological links but also demand integrated, evidence-based, and patient-centered approaches. Over the coming sessions, we'll explore emerging therapies, transformative research, and educational innovations that are reshaping cardiometabolic medicines. We are truly honored to have with us today a distinguished panel of experts, respected cardiologists, diabetologists, and endocrinologists from Kenya, Uganda, Rwanda, and also from Egypt. So before we begin, I would like to thank the Dark-Eyed Association for their collaboration and to all the doctors for taking the time to join us here and contribute to this academic exchange. So once again, welcome to ACME 2025. May this event inspire us all to breathe knowledge and compassion and to continue transforming the landscape of cardiometabolic medicine for healthier tomorrow. So before we dive into the exciting sessions ahead, let's take a moment to celebrate our journey, our milestones, our growth, and the vision that unites us. To begin, may I request to kindly direct their attention to the screen for our Ajanta Pharma corporate video.
Ajanta Pharma is a multinational pharmaceutical company producing a comprehensive range of specialty products, customized to each market it is present in. Ajanta's business includes branded generics in India and emerging markets, generics in USA, and institutional supplies under WHO program in Africa. In India, Ajanta ranks 26th as per IQVIA. It has presence in therapeutic segments of cardiology and anti-diabetic, ophthalmology, dermatology, and pain management. With over 300 plus products, Ajanta has consistently provided innovations in patient convenience and compliance. Emerging markets business includes 30 countries in Asia and Africa. Here Ajanta provides differentiated basket of brands in various therapeutic segments. With more than 200 products. In USA, company has a meaningful presence. With over 46 products on shelf and many more under approval. Ajanta's success is backed by its strong R&D capabilities. It has an advanced R&D center in Mumbai with over 800 plus scientists. Ajanta operates with 7 state-of-the-art manufacturing facilities, including 2 approved by US FDA at Pathan and Dahej in India. Ajanta has been working tirelessly to make this world a better place. Its endeavors have earned many recognitions.
So thank you. That was truly inspiring to see Ajanta Pharma's journey and commitment to serve mankind by providing quality medicines. Now to carry that spirit forward, I would like to invite our Senior General Manager, Sales and Marketing, Mr. Sanjeeva Reddy on stage.
Yeah, it's okay. Good morning, everyone. I think it's a wonderful to see all of you here in Egypt. We used to meet in Tanzania, Uganda, many of you. And it is really great to host all of you in Egypt for this ACME 2025 on behalf of Ajanta Pharma. So we have delegates from Uganda, Kenya, Rwanda. Unfortunately, our Tanzania doctors could not travel because of some political issues, and the flights were cancelled. We were trying for the last minute, but we could not make up because the flights are resuming on Saturday. So next time we'll have a bigger thing, but definitely this is our second program, and it is a great pleasure to have all of you for this particular event. Coming to Ajanta Pharma, I think the presentation showed that we have 7 world-class manufacturing facilities, 2 US FDA facilities, and the products which are going to US, also the same products are being supplied to the African market. So that is the quality we are providing to African markets. And we have close to 100 plus products in Africa currently, and we are operating 30 plus countries in Africa, East Africa, West Africa operations, and we have 25-30 years of presence in the African markets. So that also shows the commitment of Ajanta Pharma, almost 25-30 years of presence in different markets. And we are opening newer countries also. Recently we have opened the Burundi operations, Zambia operations, Rwanda operations. So we are why I am telling this, we are a very serious player when it comes to the African continent, okay? And we are among the top number 2 company in West Africa operations. So you can see our presence in African market. Coming to the cardio-diabeto products, we have 40 plus cardio-diabeto products in the Africa. And recently, many of you have witnessed the number of products. I think every alternate months, we are launching products, whether it is Empadil, whether it is Besicor, Citapril, Diazac, so many brands, Synod, first time, many products are first time also. Sitagliptin, Synod, Sinlidipine is a molecule which we have introduced for the first time in the African market. There is no other companies having Sinlidipine, Synod in the market. So we are a serious player, that is one point. Secondly, this venue, I think I should thank Tushar, Dr. Ashraf, they have helped us to host this venue. This is one of the wonderful countries. Many of you are visiting first time, even including me and my team. So we will definitely have a great experience. Egypt is a country with rich culture and rich history, and pyramids are among that. We are all eager to see the pyramids because it is among the 7 wonders of the world. So with that, I would like to thank and welcome once again each one of you. We will have a very good program. We did not only wanted to do a sightseeing, we wanted to have a mix of a science and a fun. So this will definitely a very serious scientific program. This is a case study based program, so you will love. It will be a very interactive program wherever these sessions are going on. So with that, I would like to invite Mr. Prashant Shah. He is my colleague who is based in Uganda, and he is looking after Uganda, Rwanda, Burundi, Zambia operations, 4 countries. So welcome Mr. Prashant, and thank you.
Good morning to everyone. My sincere thanks to Dr. Ashraf for nice arrangement, and I am highly inspired by presence of Professor Adel here for this DICARD program, and we are doing this activity since 2018-2019 ACME program, and this is a continuous journey, and I am going to share Ajanta once again re-emphasize on the scientific aspect on cardio-diabetic segment, and we want to be enriched with that recent trend and recent concept and recent guidelines in diabetic and cardiology, and this is the platform which is going to help us and clarify many things which is not clarified at our day in, day out. So this non-communicable disease, cardio-diabetic and metabolic disorder is the next decade challenge. So we are starting this today forum with DICARD, and under leadership of Professor Edel, we are going to understood many things today, and my sincere thanks to everyone to be here on our invitation. Thank you, thank you. Have a nice day. I am also inviting my colleague Pinesh. Please come.
Hello everyone. So Egypt is a great place, right? So let's say great morning rather than the good morning. Great morning once again. Yeah. So first of all, I want to say thanks to all of you that your valuable presence and make this event successful. Myself, Ines, I'm taking care of Kenya operation, and I am witness when we launched this cardio-diabetic product and currently with your all supports, we can say that now we can say that Ajanta products are there. Second thing that I just want to share my experience. That I never, my 4 years experience in Kenya, I never heard that any of the doctor, any of the patient had make any complaint about the Ajanta product. So I give the confidence, even the slides you can see that's how serious about it. Ajanta known for that quality of brands and affordable pricings. So please continue your support and thanks. And with this, I want to invite Mr. Dana.
Good morning, everyone. Good morning, everyone. Thank you very much for the energy. First of all, I would like to thank all of you for traveling all this way for attending this great program of Ajanta Pharma. So my name is Dhanavendan Subbayan. Rather than saying my short name, my doctors will say, thank you so much. So my name is Dhana in a short. So I have a total 18 years experience. This is my first international assignment. So I'm really thankful to Sanjeeva sir and Prashant sir and my hierarchies and my MD sir for giving such a wonderful opportunity to work in international business. So I'm in Uganda. I'm handling 6 divisions. So majorly I'm handling cardio-diabetic, so which you all are witnessing. So this is my first program in international. So I would like to say only one thing. Ajanta Pharma is known for academic because I have witnessed in Uganda. Many companies are there, they are competing with us, but they are doing a lot of activities like other activities. But whereas Ajanta Pharma is very serious in terms of doing academics. So our motto is to motivate the doctors, patients, even pharmacists, procurement officers, even dispensers, because these all people are playing key role in terms of making the patient's life better. So in terms of that, we have did many programs in Uganda, ECG workshop, decode, many things, and this is the one of the important program. So as Sanjeeva sir told, this is our second program and it is going to be continued year by year. So for that, we request all of you to support for Ajanta Pharma's products so that we can do better, much what we are doing now. So you all are going to explore much better than what you are explored yesterday, Egypt and scientific feast also. So I'm looking forward for your great support. Thank you so much. I'm sorry, let me ask Mr. Tushar to take over the dais.
Good morning. Tusanuse okubalaba. Karibuni. Alan biku kuluku. So I said welcome to all of you in the local language. Okay, so in India we say namaste. Okay, and I think there is no introduction for me. What is my name? Tushar. So that is what I'm from marketing team. So I'm working as a senior marketing manager. I'm looking after for the East Africa market. Apart from Tushar, I just want to say you remember this. Empadil, Cetapilin, Basicor and Synod. Okay, and I'm going to have the session afterwards. I will not take much time of all of you. So let's start with the next session. Thank you. Shukran.
So thank you our team and respected seniors for setting the tone of the teamwork and the inspiration as we begin this ACME 2025 event. So let me just brief today's agenda for ACME 2025 event. So it will include ACME theme reveal session. Then we'll have a case study presentations by our speakers, followed by a presentation by Professor Edel. So the objective is to enhance our understanding of the latest evidence-based guidelines, novel therapeutics, and the practical approaches for patient-centered care. So it's my great pleasure to introduce the honorable moderators for today's session. So we have Professor Edel, who is a consultant cardiologist, who is the president of DICAD Association Egypt. We have with us Dr. Emmanuel Seka Sanwu, he is a consultant nephrologist from Uganda, and Dr. Kuria Kamau, consultant cardiologist from Kenya. I will request Mr. Sanjeeva Reddy to present the bouquet to our honorable moderators. So thank you everyone. I would like to invite Mr. Tushar on the stage to reveal ACME 2025 theme.
Okay, so welcome all of you once again. So as you know, our program name is Ajanta's ACME. Okay, Ajanta's CME. So it's called as short form ACME. So our objective of conducting this program, as you can see, that we want to engage the key opinion leader of the East Africa market, and we want to associate with the scientific association. As you see, this time we have associated with the DICAD Association, which is one of the renowned association in the Egypt. So likewise, every year we want to engage with the different association, and we want to create one platform where all the doctors can come together from the East Africa, Kenya, Uganda, Tanzania, Rwanda, Zambia, and we can have the one platform where we can discuss and interchange our knowledge. Okay? So currently in this hall we have 31 doctors. From Uganda we have 16 doctors. From Kenya we have 14 doctors, and from Rwanda we have 1 doctor. So as I told you that we have the tie-up, or we have the collaboration with DICAD Association. Professor Adel is there. So he is president of the DICAD Association. So we have the tie-up with them, and so with this we have created this Ajanta's ACME this year program. Can anyone know? Do you know this? Who is this person? Can anyone guess? We are in Egypt. You know this person? Anyone knows? You might heard this name when we will go to the pyramid. That time we will heard this person name. Any guess? Yes, sir.
Kamun, Tuta.
No. Okay. So he is not that person. Any other guess? Yeah. Ramses, no. Any other guess? Dr. Lutai Peter, any guess? No? You are searching on Google? Okay. So this person name is Imhotep. Okay, correct me if I am wrong spelling. Is it correct? Imhotep. So you can see, long before modern science, Egypt gave the world first physician, world first architecture, world first astrologer is Imhotep. So we are standing in the place where this person was there. Okay, in this land of gods and kings, under the shadow of pyramids, medicine was born. Today we gather all of us here where it all began, not just to share the knowledge but to reignite it. Okay, so the theme what we have this time is unite to reignite. So all of us are united here to reignite our knowledge. So that's why this year we kept the theme unite to reignite. I hope you liked it. Yeah, okay. So now I request our all moderators we are going to unveil the theme with one activity. Since we are in Egypt, we are going to play some Egypt music and we are going to have one activity. So I request Sanjiva sir and Mr. Prashant, Mr. Pinesh, Mr. Dhana. Yeah, Mr. Dhana and Dr. Sekasanu, please come here. Sir, Dr. Sekasanu, you want a hat? Okay. Great, great, great. So all of you in the tea break, this is the king hat. So there the photo booth is there. You can wear this king hat and you can have this stick also in the hand. So you can have the nice photos. Okay, it's an instant print photo. So in the tea break, lunch break, you can do it and it will be available till 3 o'clock. So you can do that one. So with this, I request our audiovisual person to play the video. So we have created one video for this ACME. So this video is specially created by AI. You can see how we have created.
Of gods and kings, medicine was born. The birthplace of healing. From the wisdom of Imhotep, the world's first physician, to the ancient Ebers papyrus, Egypt's medical legacy is the foundation upon which we build. Where ancient wisdom meets modern science. A new dawn of knowledge. Today, we gather where it all began, not just to share knowledge, but to reignite the flame. Unite to reignite.
From the Nile to the heart of care, we gather together, knowledge to share. Tanzania, Uganda, Kenya unite. In Cairo spirit, our future is bright. Learning, healing, hand in hand, building hope across the land. Together we rise, together we stand, with every heart, with every plan. Unite to reignite the journey we start. Cairo is calling, uniting every heart. With Diana by our side, knowledge and care will be alright. Ajanta's vision, lighting the way for doctors of tomorrow, today. Science and passion, woven as one, for healthier lives, the work is never done. Ajanta's vision lighting the way for doctors of tomorrow, today. Science and passion woven as one for healthier lives. The work is never done. Learning, healing, hand in hand, building hope across the land. Together we rise, together we stand. Unite to reignite across this land. Unite to reignite across this land. Unite to reignite the journey we start. Cairo is calling, uniting every heart. With Diana by our side, knowledge and care will be alright. Ajanta's vision lighting to the night, every moment, every mile. Stronger together, wisdom we share. Unite to reignite beyond compare. Knowledge and care will be alright. Unite to reignite our promise, our song. Together in Cairo, where we belong. With hearts united, knowledge shines through. For every life, for me and you. From East Africa to the Nile, every moment, every mile. Stronger together, wisdom we share. Unite to reignite beyond compare.
So let's unite to reignite. You see the magic that Nile starts from where? Jinja in Uganda. And you can see the Nile here. So the water is connect. So it's a unite to reignite. Okay. So now you must be seeing that we have done activity where we have discussed about the emotive. Okay. But the architecture what he has developed, it's one of the main thing which Egypt is known for is pyramid. Okay. So I want all of you to contribute to build the pyramid. So we are going to build the pyramid here. So what I request, now I am going to call from each table two doctor in the front. They have to introduce themselves. Okay. Then you have to take this brick. This is the imperial brick. Okay. So this brick, you have to just keep it here. Okay. So you have to keep it here. You have to introduce yourself. You can tell about your experience and all these things. Then the second two doctors will come. They will keep the second brick. Likewise, we are going to create a pyramid here. So we want to have the interaction with all of you so that Uganda, Kenya, Rwanda doctors will have interaction. Also Dr. Adel, Dr. Ashraf will also came to know that what is your experience so that our session will be much more fruitful. Okay. So we'll start with from this table, Dr. Mutebi Idrissa and Dr. Mozwa, you can please come forward. Yeah. So you can introduce yourself, then you can keep the brick.
Good morning, everyone. I'm Idrissa Mutebi from Uganda. How much introduction do you want? The number of women I have, the children I have.
Just remember that in the night you have to go to Nile cruise. So I request you can make within 1 minute or 30 seconds as short as possible.
I'm an endocrinologist from Uganda, and you're all welcome. Thank you.
Good morning. My name is Dr. Musa Moses. I'm from Kenya. I'm really having fun. Thank you.
Yeah. Yes, I request second table, Dr. Lutai Peter and Dr. Please come. Dr. Mokoba Hankani. Yes.
Morning, I'm Dr. Utaya Peter. I'm from the source of the Nile, Uganda.
I'm Dr. Anthony Makoba from Uganda also, practicing in southwest Uganda. Thank you.
Okay. Now next table, sir, please. Ma'am.
Good morning, everyone. I'm Dr. Eugene Nkusi from Rwanda.
Good morning, everyone. I'm Dr. Kibadi from Kenya.
Ma'am, please. If you want, you can have a little more introduction.
Good morning. My name is Emily Juno from Kenya. My first time in Cairo. I'm very excited to be here.
Good morning. I'm Dr. Edward Mutuku from Kenya. I'm grateful to the organizers of this event. Yeah, thank you.
Okay. Thank you, Doctor. Dr. Asad.
Morning, I'm Dr. Asad from Jinja, source of the Nile. Thank you.
Good morning, I'm Dr. Mary Paul from Kenya.
From India.
Dr. Izra, Dr. Majwala, please come.
Good morning, everyone. I'm Dr. Majwa Albert from Uganda, the Power of Africa. Good morning. Hello. I am Nunda Ezra from Kampala, Uganda, working in the second oldest hospital south of the Sahara, that is Mengo Hospital.
Now the second slab. First slab is complete, empire slab. You have to put this. Right, that's perfect.
Thank you, Doctor. Thank you.
Next to Doctor, please. Come.
Good morning, Dr. Jakai Charles. I practice in Kenya, Eldoret, the source and the city of champions, where all the runners who beat the world come from. I'm happy to say I'm the physician of most of them.
Good morning. I'm Dr. Rosie Nrofu from Kenya, Nakuru, the county of unlimited resources. I'm grateful and I'm thankful for Ajanta Pharma. Thank you so much.
Thank you, Doctor.
Okay, I request next two doctors, please come forward. Yeah.
Yes, good morning. I'm Dr. Nsuluga Martin from Kampala, Uganda. I'm from the Pearl of Africa and the source of the Nile.
Good morning. I'm Peter Ngatia. Peter Ngatia is a Principal Clinical Officer, Nairobi County, Division of Non-Communicable Diseases. Thank you very much.
Thank you, Doctor. Very good.
Next two. Okay. Next two doctor, please. How many are pending? We have so many bricks.
Everyone is going to be. Yes, Dr. Rose.
Good morning. My name is Rose Muhindo. I'm a physician and a senior lecturer at Bara University of Science and Technology in the Department of Internal Medicine. I live and work in Bara, the land of milk and honey, and I am a proud nephrologist.
Good morning, everybody. I am Dr. Barbara Kakande. I'm a cardiologist in Victoria Hospital. I'm a big sister to many of the Ugandan doctors, and and baby sister to Dr. Sekasambu and Dr. Raymond. So welcome to this session. I hate the cold, So I look forward to the rest of the sessions outside here.
Yeah. Thank you, doctor. You need to build the brand. Yes, doctor.
Good morning. Dennis Mugalu, endocrinologist from the basis of Lake Victoria in Uganda.
Good morning to you all. I'm Sylvester Semanda from Kampala, Uganda, the Pearl of Africa. Thank you very much. Asanteni sana.
Our third slab, basic or.
Doctor. Yes, Dr. Raman, Dr. Charles.
Morning once again. I'm Dr. Mwebaze Raymond, and I'm a physician at St. Francis Hospital in Zambia. I actually grew up in my O-level years at the source of the Nile. Thank you very much.
Good morning, everyone. I'm Dr. Mutoke Charles. I'm a cardiologist from Uganda. I work in Mulago National Referral Hospital, and I come from the South of the Nile. Thank you.
Next. Thank you, sir. Yes, please come, doctor.
Good morning, Sabah al Khair. I'm Dr. Nadia Alian from Kenya, Kilifi County, and I work at a hospital which is by the beach, by the way. Karibuni sana Kilifi. And once Ajanta, always Ajanta. Thank you.
Good morning, everyone. My name is Dr. Kuria Kamau. I work in Nairobi. Otherwise, Nairobi is the only city that has a national park inside the world. So you're all welcome to Nairobi, the national park. Thank you.
Thank you, doctor. You can put the plate. Yes, well done.
Yes, thank you.
Thank you.
Now, how many are pending? Only one, sir? Okay, sir. Yeah. Okay, yeah, please come, sir. We have the bigger responsibility, Ajanta Pharma.
Good morning, everyone. I'm Moses Chiwanika Sembiwa. I'm a new cardiologist on the job. I was trained by Dr. Barbara. Dr. Barbara, I work with the Uganda Institute, but the person who gave me the job there after finishing internship was Dr. Barbara, because she interviewed me. Yeah, so I see her as a mother to me in cardiology. Thank you very much.
Good morning, everyone. I'm Lucinda Kenneth. I come from Kampala. I'm a very elderly man. Glad to be here.
Morning, everyone. This is Dr. Isaji. I'm from Kenya and I work in Mombasa, the city of tropical sun and white sandy beaches. Thank you, Ajanta, for having me here.
Put Ajanta Pharma strong bricks.
Yes.
Yeah, strong foundation.
You all can come from behind.
Yes, Ajanta away.
Empadil Oe, Sitapril Oe, Basicor Oe. Thank you, doctor. Thank you.
Okay. So I hope all doctors are done. Anyone pending to build the pyramid? Huh?
Yeah, please come.
So I request Dr. Beryl and our moderators also to please come forward. Dr. Seka Sanu, Dr. Adel, Dr. Kuria Kamau, please come forward. Because there is something is pending at the last. So first of all, let me give the mic to Dr. Beryl.
Good morning, everyone. My name is Dr. Beryl Muyobi. I'm from Kenya. Yes, from a small county called Kisii County, where we have many cases of diabetes, and I'm happy to be here. Thank you to Ajanta Pharma for sponsoring this.
Dr. Emmanuel Sekasambu. I'm a nephrologist from Uganda.
I'm Dr. Adel Trebi from Cairo. I'll have very few words if you allow me, now or later. What do you think? Yeah, okay. I am actually I founded the Diacarb Association long before the concept of CRM has evolved, because I knew that there has to be a cooperation between subspecialties, and we started with nephrologists, diabetologists, and cardiologists. Now I'm really very proud to have you all here in Egypt, the cradle of civilization, and I hope you will enjoy your time, and thank Ajanta company for allowing us to be cooperating in this very peculiar event. I hope you will enjoy Cairo, and you'll enjoy tomorrow the Grand Egyptian Museum, which luckily enough you came after its official inauguration, and this is the perfect timing to visit the Grand Egyptian Museum and of course the pyramids, and I hope you'll have a nice time in Cairo. And let me thank of course Ajanta company for allowing us to be cooperating, and Dr. Sanjeev and all the team. I don't want to lose the names, but thank you very much for coming, and I'm very proud to have you all with us today, and a very fruitful meeting, inshallah.
Thank you.
Okay, yes, sir. I think you already introduced.
I already introduced myself. My name is Dr. Kuria Kamau. I run a cardiac clinic in the outskirts of Nairobi, where we aim to actually provide cardiac services to the underserved. And I'm very happy that Ajanta has come into the market, and they are giving us very good products at rates that my patients do not complain about. So thank you very much, Ajanta. Thank you also for this opportunity. It is a great time that we are having here.
Okay, great. Okay. So I request all the doctors please come behind, so we can have the final brick, that is unite to reignite, along with all Ajanta brands and all the doctors of Uganda, Kenya, Rwanda and Egypt. Let's unite to reignite. The pyramid is going to complete. I want all of you to please clap loudly. Thank you very much, sir. Thank you. So today all of you have become who? Emotive. You all are emotive. Okay. So you have also one of the good architecture. You can see the nice pyramid has created. Okay. So I request all of you to please remember this pyramid in your mind when you go to the country. Okay. So now with this, I will just have the short presentation of our brands, since we have very less time. So I want to also make it fast. I just want to ask this question. Can you please tell me what is the difference between this image? I discussed this image in Uganda and Kenya presentation also. Anyone remembers? Typewriters and what is? Okay, but what is the difference? What you understand from this image? Old and new technology. But if you see from my eyes, This side, it's other company, that side is Ajanta Pharma. The point I want to mention here, if you see the companies which are available locally in Uganda, Kenya, Rwanda market, these are the company who are the kind of distributors. They just see any product is moving, they just bring the generic molecule in the market. We don't know the quality of the product. Ajanta Pharma, as you can see in the video, there are 7 art of manufacturing plants, US FDA plants. So we are the branded company. And we don't launch the brand which are the Me Too kind of brand. Like for example, Amlodipine is moving fast in the market, we are not launching that one. We are coming with the Synod, which is the next generation CCP. We are launching Empadil, we are launching Dizac, we are launching the combination. So we are spending money on this. The objective I want to discuss with all of you, that Ajanta Pharma known for the quality products at affordable rate. So as all of you know that this page you must have seen when our medical rep visits you, to empower the type 2 diabetes patients' lives, we have Empadil 10 mg and 25 mg. You already know the science behind this product. I will not take much time, but about the combination you just see, if the product is not controlled, if the patient is not controlled on the monotherapy, you can shift the combination therapy Empadil M, which comes in the 4 strength 5 by 500, 5 by 1000, 12.5 by 500 and 12.5 by 1000. And you know all the benefits. There is a better reduction to HbA1c. Then 70% of patients have achieved the HbA1c. There is a weight loss is there. So all these benefits are there with the Empadil. Similarly, we also have the other product dapagliflozin, that is Dizac. So currently in Uganda market we have Empadil, all the strengths are available. Dizac also available. And in Kenya market we have the Dizac available. Empadil soon we are going to launch. While in Rwanda we have currently Dizac product is there. So Cetapil M, it is available in all the East Africa countries. You know this brand very well. Sitagliptin along with the combination metformin. We have the 4 strength Cetapil 50 mg, Cetapil 100 mg. Then we have the Cetapil M 50 by 500 and 50 by 1000. You know the benefits of this. All these benefits, no hypoglycemia. All these points you all knows. Our medical reps comes and discuss with you. So I will not go into that. Then the third product is Basicor, the selective beta blocker. Currently this product is available in Uganda and Rwanda market. So please pass on the benefit to your patient. It available in the 2 strength Basicor 5 mg and Basicor 10 mg. And the last but not least product which I already discussed with all of you, it's a Synod, the brand of Cilnidipine, which is having the benefits, less chances of pedal edema, then increases the insulin sensitivity, reduces the reflex tachycardia and offer renal protection. So I request all of you, whenever you prescribe any medication to your patient, you just remember this slide. Okay? You always try to give the best medicine to your patients. Okay? With this, I want to say only one thing to all of you. Naipenda Kenya, Jagala Neo Uganda. So basically I said I love Uganda, I love Kenya, I love Rwanda and I love India. Now I love Egypt also. Shukran. Okay. I will hand over the session to Ms. Hemangi.
So thank you everyone for participating in the theme revealing session. It was a wonderful experience to everyone. So today here we are united to reignite it, right? So with that light shining bright, both on stage and in our hearts, let's carry the same energy into the rest of the day. So together, let's continue to unite to reignite our curiosity, our compassion, and our commitment to architecturing the healthcare. So now moving ahead, we'll start with the case study presentations. And today we have the honorable panel of our moderators. So let me introduce them in a brief. So today we have Dr. Sekasanu Emmanuel, who is a consultant nephrologist at Panorama Medi Services, Kampala, Uganda. He is a national mentor for the International Society of Nephrology in Uganda. He is a lecturer at the Uganda Matrius University, the past president Association of Physicians of Uganda, committee member Uganda Medical Association, and he has a lot of publications and presentations done on a renal care. We have Dr. Kuria Kamau, consultant cardiologist at the Heart Care Clinic, interventional cardiologist at Kenyatta University, teaching referral and research University Hospital, and is a member of Kenya Cardiac Society. And we have today with us President of DICAD Association, Professor Adil. He's one of the pioneers in the field of interventional cardiology in Egypt, the Middle East and North Africa. He is the head of the cardiology department at Ain Shams University, board member the Egyptian Society of Cardiology since 1998. He is a past president of the Egyptian Working Group of Interventional Cardiology and Egyptian Society of Cardiology, fellow of the European Society of Cardiology and fellow of the American College of Physicians. And he is the founder and chairman of DICAD Association. So today we have honorable moderators with us, and we'll have 4 case study presentations. We'll start with a case study by Dr. Beryl Muyodi from Kenya. It's on the unraveling the triad, CKD, diabetes and cardiovascular disease. Followed by, we'll have a case study by Dr. Barbara Kakande, who is a consultant cardiologist on calcium channel blockers tried and trusted. Then we'll have a case study by Dr. Muzawa Moses, consultant physician from Kenya, on SGLT2 inhibitors in the heart failure, shifting treatment paradigms. And we will have a case study by Dr. Mutebi Idrisa, a consultant endocrinologist from Uganda, on integrating 2025 guidelines into practice, that is the latest guidelines by ADA, ESD, IDF. So as we embark on this exciting scientific journey together, I encourage everyone to engage actively, ask questions, share experiences, and foster collaborations that will continue beyond this conference. I would like to invite Dr. Beryl for the first case study presentation.
Yes. I request all the moderator, please. Dr. Kuria, come out. Dr. Seka Sanu, Dr. Adil, please come.
Good morning, everyone. My name is Dr. Beryl Muyodi. I'm a physician currently working at Kisii Teaching and Referral Hospital. I hope you are all well. I hope you are all enjoying your stay so far in Egypt. I really appreciate Ajanta Pharma for the sponsorship and DICAD Association for the invitation. So as Tushar said, we are united to reignite our knowledge today on diabetes, cardiology, renal disease, so that when we go back home, we can be able to help our patients and improve healthcare. So I will start off with a case presentation on unraveling the triad, CKD, diabetes, and cardiovascular disease. It may be a complex case to some, it may not be to some. So as we go along, all of you will find some things that you can relate to, and if you have any questions, we'll be pleased to answer at the end. So I have a patient here who I saw at the diabetes clinic in Kisii County. We have a diabetes clinic there every week, and we see around 40 patients in every sitting. So this is a female patient who came in. She was 68 years old, and she had been diabetic for 15 years. Her BMI on that particular day was 24 kg per meter squared, which is within normal range. She also was hypertensive, and she was on metformin, gliclazide, antihypertensives, and a statin. So this current visit, she was just coming for review. There were no complaints. She was okay and compliant on her medication. But upon further clinical assessment, we found her blood pressure to be normal at 135/90 with a heart rate of 76. And then her HbA1c was still not at target. It was at 8.6%. At her age, our target is usually around 7 to 7.5%. So she was not within target in terms of glycemic control. Then her fasting blood glucose was 10.5, which also I found not to be within target, because for a patient who is on medication, our expected target is between 4 to 7. Then her lipid profile, which we had requested for, was normal. Her renal function was abnormal. She had an EGFR of 55 mils per minute, which indicates CKD stage 3A. Then her liver function tests were normal, and her weight was normal at 66 kgs. So this is a typical presentation. Most of the patients we see in diabetes have one comorbidity or the other, multiple comorbidities. Like our patient here had diabetes plus hypertension, and now she's progressing to CKD. So this is a patient with diabetes, hypertension, and CKD stage 3A with poor glycemic control as evidenced by the HbA1c of 8.5, and she's very much compliant on medication. So how are we going to go about managing her so that we can improve both her glycemic control, prevent further progression of her renal failure, and also ensure that she doesn't get other cardiovascular complications like myocardial infarction or even cerebrovascular accident in the near future. So I decided to change her regimen. She was on metformin gliclazide for the diabetes but with poor glycemic control. So for her, I initiated her on an SGLT2 inhibitor because according to the American Diabetes Association 2025 guidelines and the European Association of the Study of Diabetes 2023 guidelines, patients with diabetes who have CKD should be on an SGLT2 inhibitor. In addition to reducing CKD progression, it also prevents heart failure and also other cardiovascular complications. So we initiated an SGLT2 inhibitor for her, and we continued with the metformin because the EGFR was still not below 30, but in addition to that, we added a DPP4 inhibitor so that she can have a triple combination therapy, which will now assist in glycemic control and also in preventing cardiovascular complications. We also encouraged her to do regular blood glucose monitoring and recording at home so that in future clinic visits we can see how the trends are progressing, and we advised her also to intensify lifestyle modification and her clinic visits. So upon reviewing her after 3 months, we found the HbA1c had slowly reduced from 8.5, it was now about 7.8%, and her renal function tests are also improving. Initially there was some proteinuria which was seen on urinalysis, but upon initiation of SGLT2, currently there's no proteinuria, and we are still monitoring the creatinine and the urea closely to ensure that it doesn't progress from 3A to end-stage renal disease. Yeah, so that is what I have for you today. So any questions up to there?
Thank you very much for the presentation, but I want you to elaborate on the EGFR and what are the gliflozin uses for EGFR. And we have, of course, Dr. Sexano with us, and he's a nephrologist, so he can give us some insights about the EGFR and when to use it, and what's the lowest EGFR allowed for SGLT2 inhibitors.
Okay, I take it up or I give, okay. From the guidelines, the SGLT2s are allowed up to a cutoff of 25. So for our patient, the EGFR was 55, which was stage 3A. But once a patient is 25, EGFR of 25 and below, we usually are a bit cautious in terms of initiation of SGLT2 inhibitors. However, there are some randomized controlled trials which are still underway, and in future we believe that the cutoff point will be even lower. Yeah.
The point with the SGL2 is that they are not harmful to the kidney, but if the GFR is low, they will not work. They need a properly functioning kidney to work. So once the GFR goes down, the effect will be less, right?
Yes.
I think empagliflozin is for the 25 and the DAPA for 30, right? I mean, for the studies.
Yes.
Okay. If there are any questions here? Okay. Can you please give the mic to...
Thank you, doctor, for your presentation. You said this patient has been with diabetes for 15 years now.
Yes.
That's quite long, 68. She's 68, is it?
Yes.
So you have only looked at the EGFR 3A. Is she spilling protein in urine? And Then have you considered adding on an ARB on this patient's treatment? And then also have screen her for retinopathy in view of the nephropathy that is setting in. So it's microvascular assessment as a whole, so that you have a complete assessment of this patient and protect everything, retinopathy and nephropathy as well. Thank you.
Okay, thank you for the question. So this patient had proteinuria. In our center, we don't have the capacity to do urine microalbumin, but we usually just send them for the basic urinalysis test. And the patient initially had a proteinuria of 3+. Upon initiation of the SGLT2 inhibitors, we have been following up the urine results, and the proteinuria has reduced to 1+ currently. Then in terms of the ARB use, she's also hypertensive. So she was on antihypertensives. For us, we did not choose the ARB, which was the S, which I believe also assists in reducing proteinuria. And then when we evaluate our patients in clinics, we look at them as a whole because they have these cardiovascular diseases which can have the complications of retinopathy, nephropathy, and the rest. So with each clinic visit, we usually link them up with an ophthalmologist, at least an annual ophthalmology assessment for every diabetic patient, yes. So the patient had ophthalmology evaluation, but at this point she did not have retinopathy. The only cardiovascular complication we found after 15 years of being on medical treatment for diabetes for her was the CKD, which was setting in. But in terms of she also had some neuropathy, but mild. But in terms of retinopathy, it was evaluated and was negative, yes.
Dr. Beryl, in your presentation, you mentioned that you wouldn't stop metformin until the GFR is 30 mils per minute. Of course, that is as per guidelines, but when you look at environmental medicine where we practice, we always have very heavy clinics. Patients are given long review periods, and the default rates are high on the appointments because of various reasons. So for practicalities, we always would not allow patients who have a GFR of 40 or less to continue on metformin. So I think it would be a very good approach, other than following the guideline very strictly.
Okay, I agree with you. Our patients have long duration of review, mostly 3 months to 6 months for most of them. So whenever we meet one, we try as much as possible and optimize because we don't know when we are going to meet them again. So for this particular patient, her eGFR was 55. So yes, there was that option of stopping metformin and maybe combining the DPP4 with insulin, and then also in addition to that the SGLT2, but at this point she was fairly stable, so I considered just combining metformin and DPP4 plus the SGLT2. But yes, you try and optimize as much as possible with each visit. Yes.
Thank you.
Okay, I'm Sylvester from Uganda. Thank you very much for the well summarized presentation. I just wanted some more clarity on the antihypertensive regimen. You mentioned the SCI. I wanted to know that it is monotherapy or there is something you added onto the SCI as well. Thank you very much for, of course, also elaborating to us how the HbA1c improved on change of the regimen. But also in regard to the hypertension, I would like to know a little bit more about the what would be the desired blood pressure target, and whether we have a general impression of the overall blood pressure control of the patient beyond the single reading of 135/90.
Okay.
Thank you very much.
Thank you for the question. So for this patient, she was on antihypertensives with good control. She was on a combination therapy of nifedipine, 20 milligrams twice a day, and the enalapril 10 milligrams once a day. Upon this clinic visit, her blood pressure was 135/75 with a pulse rate of 76. However, part of our management plan was for her to do regular blood pressure monitoring at home and recording, so that with each clinic visit, we can be able to see the range. So as much as possible, most of them usually don't have the blood pressure machines at home, but with each visit, we try and recommend them to buy their own blood pressure machine, their own blood sugar machine. We encourage them to take the measurements at least twice or thrice a week and record. And when they come for clinic visits, we usually check the records. So for her, she did not have a record at that particular visit, but part of our management plan was for her to start the regular monitoring and recording. And then in terms of the second question you asked was about, you asked about the blood pressure reading, the monitoring, and the target, yeah. So the target for a diabetic patient with hypertension is below 130/80 as per the current guidelines. So for her, it was around 135/75, which was slightly off target, but still not very worrying. But with that record, the recorded range, we can be able to tell in future visits, yes.
Thank you, Doc, for that lovely presentation. My name is Ezra. My questions are 3 or 4. The first one you already answered, you're unable to do urine albumin creatinine ratio, but by look of things, this patient is probably A3 by the time they have macroalbuminuria. Did you manage to classify this patient? I come from a privilege, I'm endocrinologist, so I come from Uganda. We've done a study that helped us to classify our patients, which probably spills over to Africa, where we have about 65% of our patients being insulinopenic as opposed to insulin resistant. This patient sort of seems to be falling in the line of insulinopenia. So did you manage to do a C-peptide for this patient to inform on which drug of choice? Because I saw the patient was already on a sulfonylurea, and I don't know whether you changed the sulfonylurea to what was the thinking behind adding a DPP4 on this patient, because that would be another guidance to say C-peptide is low, this patient's pancreas is running dry, and probably introduce something. And then 3, was this patient started on a statin? Because we know, as per guidelines, urine albumin creatinine ratio of A2 and above, high-risk patients, give them a statin, and which would be your first choice statin. And lastly, in the harmony of guideline-based management, local data, we have now seen that the foreign or the European guidelines might not necessarily apply to us as Africans. And thanks to the UDIP study, where we found out that actually not all, majority of type 2 diabetics are insulin resistant. Most of them are actually insulinopenic. And that's when we have the classification of type 5 diabetes now coming in. So do you have any local guidelines in Kenya as per the Kenya Association of Physicians, the Kenya Kenya Diabetes Association, or even the East African Diabetes Study Group? Did you follow those guidelines or the European guidelines? Thank you.
Okay, thank you for the question. So the guidelines are there, but in terms of implementation, it becomes a challenge, especially when you're working in a public hospital where resources are limited, and most of these patients cannot be able to afford the tests which are not based in the facility in the facility they are coming for the clinic visit. So in terms of where I work, we don't have the C-peptide test within the facility. So for such a patient, I would have to send her to a private lab for the test to be done, which was not financially feasible for her. But the guidelines, in terms of Kenyan guidelines, the Kenya Diabetes Study Group has the set guidelines in terms of when do you need a C-peptide level and how to interpret it afterwards. So for this patient, we didn't manage to do the C-peptide levels because of financial constraints, but it was one of the tests that she needed. Then in terms of insulin, in terms of her initiation, choosing the DPP4, I stopped the sulfonylurea for her because I found after 15 years she's not responding well. The HbA1c is still at 8.5. So I chose the DPP-4 because it has shown to have modest HbA1c reduction, and also it is weight neutral, and it is one of the drugs which are also safe in terms of renal care. Yes, and then I stopped the sulfonylurea for her. In terms of statin therapy, she had been on statins for the 15 years. Throughout her 15 years of diabetes care. The statin of choice is atorvastatin for us. We usually start at low doses and then we up titrate depending on the cardiovascular risk. But yes, she has been on a statin. Guidelines are really essential in terms of diabetic care, but always we remember that management of a diabetic patient is individualized based on resources that are available, and also patient compliance. So many things come into play when you are seeing one diabetic patient vis-a-vis another. So one patient may be able to afford the C-peptide, another one is not able to afford, but still we try as much as possible and look at the patient as an individual and optimize the therapy individually. Yes.
Thank you very much, Dr. Beryl. So, in the evening we have a cruise. So we need to also keep track of the time. So we'll allow one last question, and then after that, hopefully we can take the break. So I think I saw Dr. Barbara very.
Thank you very much. Thank you, Dr. Kamau, for allowing. Thank you for your presentation. Just one very brief question. What's your take on putting this patient on an MRA, for example? For protecting the kidneys, we are looking at everything here that we can grab, because the end, if she gets kidney failure per se, management is difficult.
Okay, so MRA for her is an option, but I usually personally I reserve it for refractory hypertensive cases, patients with renal failure who have refractory hypertension. So for her, at the moment I saw her, the blood pressure was already 135/75, which is fairly good control for a diabetic patient. So at this point, I wouldn't add an MRA, but in future, once I evaluate her and maybe the blood pressures are found to be refractory, that's when now I would consider the MRA. And also, for renal patients, MRA is a good option, but you also have to be careful in terms of the risk of hyperkalemia. But for refractory, I usually preserve it for refractory hypertension. But now that you are a nephrologist, maybe you can give us more insights on this. Yeah.
So let's take one final question, because in Africa, final is never final.
And this one has not been answered anyway, but I'm following up on what Dr. Nunda talked about this patient being insulinopenic. Of course, from your presentation, 15 years, probably this patient has secondary oral hypoglycemic failure already. And to me, you removed one of the most potent anti-diabetic oral agents, gliclazide. Is more potent than DPP-4 inhibitors in terms of HbA1 reduction. So, because you think a secretagogue may not work on already failed beta cells, and the DPP-4 will have to work with functioning beta cells, as far as I'm concerned. So I think on the next visit, this patient, you should consider reassessing whether she's still benefiting from oral agents and consider switching this patient to insulin. It doesn't have to be answered. Thank you.
Thank you very much. Maybe I'll hand over to the organizers and they can tell us if we are ready, or do we continue with questions? Rick?
Hello? Just one more. Looking at the case H and the improvement in HbA1c, I just wanted to inquire, is this CKD worsening? Is it why we are seeing the HbA1c improving, or it's our medication working? So how do we make that particular difference that this patient's CKD is progressing vis-a-vis we got it right. Now our medication is working and improving the HbA1c. Thank you.
Okay, I think the best way to know whether it's just the CKD improving or both is to monitor both. So for how we are monitoring the HbA1c, which is coming down, and we are also monitoring the kidneys. In terms of proteinuria, the protein loss has reduced, the creatinine levels are coming down. So for me, I would say it is both the glycemic control improving and the kidney function improving also as well.
Yeah. Thank you, Dr. Beryl, for the wonderful presentation and interactive session. We'll break for tea now. Thank you. Big round of applause for the first case study presentation.
Dr. Barbara, you are doing the next presentation, isn't it?
Yes.
Okay, so I think you better get ready. We can get the session started and running.
Yes.
So, gentlemen, men and ladies, welcome back from the tea break. We are continuing with our case studies. I have already been introduced but for the sake of reintroduction, let me introduce to you a consultant cardiologist who works at UMC Victoria Hospital in Uganda, Dr. Barbara Kakande. She's got a lot of experience in caring for heart, and she's a member of the Uganda Heart Association. She has been introduced here. So for the sake of saving the few minutes that we've wasted, Dr. Barbara, the podium is yours. And while Dr. Barbara is coming to the podium, you noted that the first presentation was a rapid and what we call a mufululizo presentation in East Africa. So this time I want you to be a little slow because there could be questions that are being generated while you are presenting. And we would like the session to be an interactive one. So don't hesitate to raise your hand, ask any question or make a comment while she's presenting. Dr. Barbara, the podium is yours.
Good morning again, everybody. The theme this year actually is very important. You notice the words are unite to reignite. So among all the drugs that we're going to have to talk about, the calcium channel blockers are among the drugs which have been taken for granted, and that's why it's really important that we remind ourselves, again, reinflame ourselves with why we use them and how relevant and how important they are. They're usually put in the background because of all these other newer drugs. You heard about finerenone and all the other novel drugs. So let's just take a step back and once again remind ourselves why the best drugs, and I'll say the best here, are the calcium channel blockers. And so let's make this very interactive. So I'll actually be doing a lot more asking you questions, because these are drugs which you've been using for many years. All your patients, I'm sure, on a calcium channel blocker. And I'm sure it's among the first drugs we used. Actually, like when we're starting, as they said, nifedipine, which is still being used. So let's make this very interactive. So the case is, I'm using exactly the same case she used, but this time it's an elderly lady of 73 years. And I'm just going to describe basically the calcium channel blockers she's used so that we can discuss and think, why did they change it? What was the relevance and what could they have done better? So a 73-year-old lady who had been hypertensive for over 30 years. So the first drugs she used in the past were nifedipine, and this was changed to nifedipine twice a day, 20 milligrams, and then it was changed to amlodipine, 10 milligrams. However, she developed lower limb swelling, so this was changed to levoamlodipine, that is the S-amlodipine. and she seemed to be stable. She was diabetic. No slides. So no, we're only doing calcium channel blockers. The slides will come. So okay, just remember the drugs: nifedipine, then amlodipine, then S-amlodipine, and then eventually, because of renal failure, she was put on diltiazem, and then eventually, because of resistant hypertension, she was put on cilnidipine. So I just want you to remember that. So just reminding you that, as Dr. Mayo said, the aim of medicine is to prevent disease and prolong life, and the ideal medicine is to eliminate the need of a physician. You'll find that when you use calcium channel blockers, most of the time the patients are so safe you rarely have to review the drugs. So you'll find that that's a benefit of this calcium channel blockers. So please, as much as possible, use them. So I'm giving an overview of the science, and then you're going to be the ones to explain to me why you think we changed from what drug and what could you have done better. So reminding you about the role of calcium in the cardiovascular physiology. This is important, especially for those who are lecturers, because the basic sciences is very important. So when you're asking your students, the SHOs, you should also be able to have the answers. So remember that in the usual physiological state, the extracellular calcium is much more than the intracellular calcium, and this is because calcium is a very powerful ion, and it actually is involved in many of the processes in the body. So remember that even just the coagulation system, remember calcium is there in the nerves, in the heart, and all the other functions of the body. So calcium is very important. So usually the levels are as low as 5 to the power times 10 to the power minus 8 moles per liter intracellularly. So what happens is when the cell is activated, there is mobilization of the calcium from the extracellular environment, and this calcium enters through channels, but there's also, remember, intracellular stores in the sarcolemma and also in the mitochondria. So remember, that also has to be released to be used by the cell. So when the calcium enters the cell, it binds onto the proteins, and eventually whatever response is expected then will happen. But just remember that calcium itself is good as long as it's transient. If it's too much, it's toxic, and therefore it's also important that the recovery is smooth. So there's a process which is also involved where there's efflux of the calcium from outside the cell and also back into the sarcoplasma, to the sarcoplasmic reticulum, as well as the mitochondria. So this is now a question. You're the ones who set the exams. Which of the following are involved in calcium regulation in the cell? You remember this was in Guyton, first year physiology. So there's the sodium calcium exchanger, there are the voltage operated calcium channels, the VOCCs, there are the receptor operated calcium channels, the ROCCs. Then you remember all the ATPase pumps, that is the calcium, which is found on the plasma membrane, as well as the sarcoplasmic reticulum and also the mitochondria. Then I'm sure you remember the calcium release channels, including the ryanodine receptors, and then there's none of the above and all of the above. So what do you think? Which one are originally? D, G, good. Who think G, who think? What do you think? All of the above, huh? All of the above. Very good, brilliant. So indeed the answer is all of the above. So when we look at the cell, remember the first one here. Here, this is the first one here is the calcium sodium exchanger, and that is also involved. Then there are the voltage operated calcium channels. Remember, the L type is the most common, is exactly the most important channel, and L is the latent, basically something which happens later, and most of the calcium passes through that. Then there's T, which is the transient channel. There's N, which is usually on nerves, very important. And remember, when we're talking about the drugs, you'll be the ones to tell me where you think the drug works. Then there's this R, which is for resting. And then there's, of course, the calcium pump. These are the receptor-operated calcium pumps and the ATPase. Then this is the sarcoplasmic reticulum, and then the mitochondria. All these have calcium pumps, and so you're going to remember this. So of course, all of you were right. It is all of the above. So this is just a reminder of the importance of calcium in the cardiovascular system. So remember, it's involved in the electrical and nerve activation, excitation, and that includes the SA node and the AV node. It's involved in myocardial contraction, in skeletal muscle contraction. Remember, it doesn't make sense to have a heart and then you're sitting and not using it. So it's important you have the heart and you're able to function, move around. It's also involved in hormone and neurotransmitter release, in gene activation, which is very important. And this is important, especially when looking at the pathology, in cell cycling, as well as in cell death and destruction. So this is just a reminder of the role of calcium in the SA node. Remember that in phase 0, especially for those Dr. Muevas and the rest who lecture, Dr. Rose, who teach students, the phase 4, phase 0, it's very important. That's where the calcium is involved. It enters and then there's depolarization. So the cell which was very negative becomes positive and then transmits to the next cell, and then eventually you have the activation of the cell. So you remember when you ask your students what phase is it, you must know. And then in the myocardial cell, if you remember the process, initially the first ion which is involved in contraction is the sodium ion. So when the cell gets a little bit of sodium, just becomes just a little bit more positive, this opens out the calcium channels. We talked about the L channels, and then there's an influx of calcium inside the muscle, goes to the, remember calmodulin, those who lecture, so it binds onto calmodulin. Then the calmodulin is going to go and activate the myosin and make sure that myosin is able to bind onto the actin, and that will cause shortening of the sarcomeres and contraction. So this is within the heart. And then within the blood vessels, remember all the calcium channel blockers mainly work in the blood vessels, in the smooth muscle cells of the blood vessels, and this is because of the calcium again binding onto the calmodulin and all that. So eventually by binding to the myosin light chain kinase, and then there's myosin binds onto the actin, and then there's contraction in the blood vessel, and that causes the vasoconstriction. So the history of calcium channel blockers, because there are actually 4 generations. I was supposed to ask you that, how many generations you know, but there are actually 4 generations, and this the first ones were developed in the 1960s. That is more than 80 years. So you can imagine how much research has been done, and yet it's one of the drugs which was very well, the science was so good that there are not many new drugs now. I mean, when you try to name them, you'll find that you know few of them, because I'm going to give a quiz where I'm asking you how many you know. But then this was initially by Dr. Edward Koroboff, who discovered the importance of calcium, and after that they developed all these different types of calcium channel blockers, and the differences are in the sensitivity to the different channels which we showed you, and the selectivity. But the majority of them, don't forget, bind onto the voltage operated calcium channel channels, especially the L type. And remember, basically you'll find that most of them are similar in the potency. That's why when one says, okay, I'm going to use amlodipine, or I'm going to use nifedipine or amlodipine, usually you'll get good control with them, as long as you know how to prescribe it. So we talked about the first generation, and the first generation, we all know them, nifedipine. The short-acting nifedipine, diltiazem, verapamil. Then the second generation were the sustained release nifedipine, felodipine, mefonidipine. Third generation include this lacidine and all those. And then the fourth generation is silnidipine. So they become more sensitive and safer, actually, with the different generations. So I remember there are 2 main types of calcium channel blockers. There's the dihydropyridine calcium channel blockers, and then there's the non-dihydropyridine calcium channel blockers. And just remember that traditionally most of us use the dihydropyridines, and these block the L-type calcium channel blockers. But remember, as we talked about, there was the L-type and then there's the N, and N-type is really important, especially in heart patients, because the N is one which is involved in the sympathetic nervous system. So you'd want to use a calcium channel blocker that is also able to block the N channels. So remember, these are vascular selective mainly, and I'll give you the reason why, because you'd wonder why is it that we use some in heart patients and some we do not use in heart patients. They actually suppress atherosclerosis, they suppress coronary vasospasm, as well as peripheral vasospasm, and eventually they've been found to reduce blood pressure variability, which is a predictor of ACS and stroke. So you've been making a good choice when you've been making sure that most of your patients are on calcium channel blockers. So the non-dihydropyridines are more of cardioselective, and I'll tell you why, and therefore they're usually used in treatment and also prevention of tachyarrhythmias. But remember that they can reduce the cardiac contractility and heart rate, so you do avoid them in heart failure. So most of you had guessed how many types of calcium channel blockers. How many do you know out of all these, the 20? So how many have you been using? How much experience do you have? So you'll find that most of you know about, have actually prescribed like 5 or 6 of them, but there are many other types of calcium channel blockers. And among the newest one is a cilnidipine, which is a very safe drug. So then among the non-dihydropyridines, don't forget there are 2 groups. There's the phenyl alkylamines, and that includes the verapamil and phenidylene and galopamil. But you find that you don't really use them, but you need to know this, especially because you will travel to go to other countries and you'll find them being used. Or maybe you'll get patients from out and then you'll see the drug and you need to remember what it does. And then there's the benzodiazepines, that's diltiazem. So this last sentence is very important because you need to know why is it that the non-dihydropyridines would be able to work on in the heart and blood vessels, and why don't the dihydropyridines work in the heart? It's because of the strength. Basically, the verapamil diltiazem is able to block the channels even when they are very negative. That is -85. And remember, the heart is the most negative because you don't want the heart to be too excitable. So the resistance to activation is so high. So you find that usually because of the being very negative, the channels are usually blocked. But then for amlodipine, because the blood vessels, you want them to be easier to activate. You want, like when you have to run and all the processes which are involved in sympathetic and cardiovascular flow, because you don't need them to be too negative. You want it to be easy for the cells to do what they need to do, so you'll find they are less negative. So you find amlodipine then is weak, and therefore it works on the blood vessels which are weaker. So just remember that you need stronger medicines for the heart and then weaker because of the voltages in the heart. So these are board questions for those who want to do board exams. So just remembering the indications. There are a number of indications for these calcium channel blockers. So in this patient of mine, initially when we started the treatment, it was used for managing her pressure, her blood pressure. And remember, the class 1A indication, treating hypertension, is their calcium channel blockers. So you're all doing the right thing when you prescribe them. So remember, they're also used in pulmonary hypertension. They're used in coronary artery disease, especially in stable angina and vasospastic angina, in cerebrovascular disease, especially stroke, prevention of stroke and after treatment of stroke, and also in Raynaud's syndrome. Many of you remember the CREST, so just remember that it helps to cause the dilatation of the blood vessels in those with Raynaud's syndrome. So that's then we go to the cardiac indication. So when do you use calcium channel blockers in heart patients? What would the indications be? Just remember that in both right ventricular systolic failure and left ventricular systolic failure, because remember, you want the heart to be able to contract. So it doesn't make sense if it's already weak to try and prevent it from contracting. Actually, you want to improve systolic function and contraction. So that's why there have been negative findings, negative effect in those who have systolic failure. However, remember that even in systolic failure, you can have a patient with a low ejection fraction, but the patient has a blood pressure of 180. So if you find that you've used the other types of drugs and yet you need to also lower the blood pressure, then it means you can use some of the drugs like amlodipine and felodipine and cilnidipine, which would lower the blood pressure but not reduce the contractility of the heart. So they will not be affected. Systolic function will not worsen. And also cilnidipine has been found to actually to improve, to reduce remodeling in the heart. So that's a very good thing, and that's because of the receptors which it blocks in the heart. So remember, for patients with the heart failure, preserved ejection fraction, by reducing the afterload, usually diastolic function is preserved or even sometimes improves. And remember that there's little effect on the heart rate with chronic use of these calcium channel blockers. So initially, especially with the dihydropyridines, remember the ones which just mainly affect the blood vessels. Initially, they may have a reflex tachycardia, because you'll have patients who come and say, oh, I have palpitations, or maybe you just measure the pulse rate, it's a bit higher. That is usually in the early stage. So sometimes they do outgrow it. And the reason, which you all know, I think you remember the science there, because of the pressures which are low. So, okay. Anybody knows why they get the tachycardia? Anyone remember why they would get the reflex tachycardia? Why the heart rate? It's just a physiological event. So what happens? Pressure drops, baroreceptors, body thinks, the sympathetic system is then activated, so then they'll get an increased pulse. But that's usually either early stage or when the doses are bigger. That is for the dihydropyridines. So remember the non-dihydropyridines, on which block the heart, the AC node and the AV node, they may be used in tachycardias, because remember they'll make the heart slower. But don't forget that when you compare with beta blockers, they'll reduce the heart rate by only about 10%, meaning if your heart rate say was 120, it will just drop to about 108. Beta blockers reduce by 30%, so there's a bigger drop in the heart rate, and that's why we find that we use more of beta blockers and these calcium channel blockers for control of the heart rates, except if there's a contraindication to the beta blockers. So we use them to treat these supraventricular arrhythmias, basically. So now heart failure is where I was actually asked to discuss this, what is the role of this cilnidipine patients with heart failure. So remember, you already know everything else, but just don't forget when you're teaching your students, cilnidipine, the difference, or what it adds on, is that it blocks the N-type calcium channel. And this N-type is the one which, when stimulated, will cause the release of epinephrine and norepinephrine, and we all know that we try to block the sympathetic nervous system in patients with heart failure. So because cilnidipine is going to block it, that is why there's actually a role of cilnidipine. It's found to be safer because it's going to work almost as well as a beta blocker. In fact, we actually do try and add it on in patients who do not have any contraindication to it, those who have high blood pressure. It's been found to improve the fractional shortening, and this is independent of the BP lowering effect. So remember that in heart failure, this cilnidipine at least, heart failure with hypertension, this calcium channel blockers have a class 2A indication for use. In patients with ischemic cardiomyopathy with, also don't forget ischemic heart disease, heart failure with high norepinephrine, you can actually give a low dose of cilnidipine in addition to the beta blocker to improve the survival rate. So, sorry. So remember, just knowing how calcium works in the body. Remember, we agreed we need the calcium in the cells. So if you block it, of course, there's going to be the ejection fraction will get worse and the heart failure will increase. Just don't forget that. So now this is where Dr. Sekasamvu and Dr. Rose and all the other nephrologists are going to help us. Are these calcium channel blockers significant in these patients with renal failure? Yes, they are. We know the ACE, the renin, the RAS system is usually the one which is targeted, but it's also important to remember that we can use these calcium channel blockers in the patients. So how they do this, they dilate the afferent arterioles, and therefore they increase the filtration pressure, and they can also facilitate natriuresis. However, remember that the difference, like this patient that I told you about, she had been on the amlodipine, and somehow there was progression of the disease So her first GFR had been about 35, and then it suddenly dropped after severe infection. The GFR dropped to 18, and she had been on amlodipine. So you can find that this can worsen proteinuria. So what happens usually in the process is because they only dilate the afferent, so there's going to be literally renal hypertension, so much blood flow because the efferent arterioles are not dilated. So the renal specialist will tell us more about this. But cilnidipine is different because it actually dilates also the efferent arterioles. So it means the pressure in the kidneys will be less. So that's an advantage of using it. Also, the non-dihydropyridines also do the same thing. So they've been found to improve function, which is why the nephrologist, actually, who my patient was seeing, changed the patient to diltiazem because they're trying to improve, actually to preserve the kidney function. You find that these are also effective in diabetics because I think you saw it. They found that one, it reduces apoptosis of the beta cells. It doesn't have so many metabolic side effects. So it's important also to use in patients with diabetes. So for the brain, these calcium channel blockers, your patients get a stroke or when they're elderly. Remember, it's one of the drugs which we've been using in patients with both in elderly patients with isolated systolic hypertension, but remember it's also used in isolated diastolic hypertension. So don't forget that. So it's been found to improve, just at least to delay cognitive decline in patients, and also it reduces morbidity and mortality in patients who've had a stroke. So I'm hoping that we have reignited our love for these calcium channel blockers, each one of you, and you'll continue to use them just from that. So usually, what are the reasons we would stop using them? I don't know, what have been the reasons mainly why you would change them? Edema, yes. What other? Yes, headache, very good. What else? So, basically, just remember that the peripheral edema occurs in, some say 5 to 70%. For me, I would just say it's about a quarter, like 25% of my patients. You know, you all have your own experiences, but it actually is a common side effect, especially the older generations. This happens because there's pre-capillary dilatation. So, of course, the blood flow, because you've dilated it, the flow will increase, but because the efferent arterioles have not been dilated, you'll find that the hydrostatic pressure in the blood vessels will increase. So, of course, there'll be extravasation of the fluid. So that will cause the edema. And also, don't forget the lymphatic system is important. What usually drains the fluid from the legs? It's going to be the lymphatics, isn't it? The extra fluid. So you find that because the lymphatics also have smooth muscle cells, these drugs will also block that. So there's not going to be the lymphatics will not be able to drain the fluid as well. So it can actually worsen edema in patients who already have lymphedema. Sorry. So other common side effects that we said include the headaches. We talked about that, and these occur in up to 50%. I don't know what your experiences are. And usually it depends on the dose. The dose of the drug will determine the headache, but some people just get the headache because 50% is a high number. But you could find that when you change from one group of calcium channel blockers, maybe from nifedipine first generation, you go maybe to the third or fourth generation, the headache may reduce. The headache is also less and even the edema, they're actually less when you add the RAS because of the physiology, the physiology. So they get dizziness, they get flushing, they get palpitations. That is only in 1%, but they can be really bad palpitations. The non-dihydropyridines, don't forget, do cause bradycardia or heart block, both sinus bradycardia and heart block. They cause constipation. How many of you have had patients who've developed abdominal symptoms because of the calcium channel blockers? Yes. Yeah, they're actually pretty common. What happens is because of the fact that the bowel has smooth muscle, So if you're blocking the smooth muscle, of course, there'll be reduced peristalsis and the gut will be less. They complain of abdominal symptoms, or you may think it's worsening of dyspepsia or something, but actually, or it's age-related. But you'll find usually the elderly people are the same ones who are on calcium channel blockers, and then the constipation will get worse. So you have to monitor for that. Don't just assume it's age causing or it's diabetes. Sometimes these calcium channel blockers do cause the constipation, so don't forget that. There are also rare side effects, which include the erectile dysfunction, but most of the studies have found that it's neutral. So it's one of the drugs which is safer to use in patients with erectile dysfunction, but I don't know, maybe you'll tell me more. And then you should always remember this, especially for the boards. Patients do get gingival hyperplasia, and this is especially after having been on nifedipine, amlodipine, and verapamil for a long time. But I can tell you I've not seen any with it, maybe because I'm not looking that well for it, but it's more common in people who have poor oral hygiene and in men, because they get actually collagen deposition in the gum, but I've not seen it. I don't know if any of you has had an experience with that. The some do get skin reactions. If anyone gets an allergy, you just know, but it's less than 1%. And also the same number, very small number of people have had angioedema from nifedipine, amlodipine, verapamil, and diltiazem. So don't assume they do not give it. So if a patient has had usually angioedema to the other causes, yes, we use it, but in case they do get another reaction, you know, yeah, that it's possible. So remember the contraindications to this drug. So which of your patients you see has any of these conditions?
Before you go to the compelling contraindications.
Yes, sir.
The side effects, like for leg edema, in case of synod, there's actually a tendency of the edema to resolve after 2 weeks of drug administration.
Yes. 2
to 3 weeks. So if actually the patient needs the drug, you shouldn't rush to withdraw it. You should give it time for the edema to resolve. And you would only be compelled to changes if it persists, or if the edema is severe and debilitating. For example, in case of women, it's got cosmetic effects, or if somebody cannot put on their shoes, that's when you would. Otherwise, if the advantage is over what you explain to the patient. Same with the headache. Normally it's like a first dose effect. Patients would get headache when they take first 2, 3, 4 doses, but afterwards they would be able to tolerate the drug. So always don't rush to withdraw the drug before you watch out for this.
Yeah, that is very important. Thank you for that. Usually they say the headache should clear within 2 weeks. So you can see if it's not really debilitating, you can try and see if they can tolerate it. And if they can't after 2 weeks, they still have it, then that's the time you withdraw, as Dr. Sekasambu has pointed out. So I don't know, remember we were just talking about why would your patient not be on the calcium channel blockers. I think you find that you've seen the contraindications. You'll find that most of your patients can be on the drugs. Because if you notice that even edema itself was not really an absolute contraindication for the patient not to use the calcium channel blocker. So remember, it's patients who get any allergic reaction. Naturally, if you're already the blood pressure is low. Patients with heart failure with reduced ejection fraction. Sick sinus syndrome, unless the patient has a pacemaker, second or third degree AV block, unless they have a pacemaker. Patients who already have severe aortic stenosis or other obstructive cardiomyopathies, because already the pressure is low in those patients usually, so you do not use it. And in patients who have accessory pathways. And remember, because the calcium channel blockers block the AV node. So if you block the AV node, it means that, especially in patients who have atrial fibrillation, if they do get atrial fibrillation, they're at high risk for getting ventricular fibrillation, because now the pathway the extra accessory pathway will be the one where there will be conduction through, so the ventricles will fibrillate. So you avoid them in patients with AFib. So also in patients who have drug interactions. For example, if a patient is on a dihydropyridine and is on digoxin, you'll worry about the bradycardia. But remember, it's not an absolute contraindication if the heart rate is already fast, because many of them have a fast heart rate. So I just wanted to ask you, how many of you have used a dihydropyridine as well as a non-dihydropyridine together at the same time. Have you ever had that? No, actually it's not contraindicated to use the two of them together because, as I've shown you from the physiology, where they act is different. So there are actually a few patients who have resistant hypertension where you want to use a small dose of something to bring the heart rate down in case there's any contraindication, maybe to beta blockers, and at the same time you want to make sure there's a good vasodilatory effect. Diltiazem is one of the better drugs because unlike verapamil mainly works in the heart, but diltiazem D, don't forget D, diltiazem dual action, so you'll find it works both in the heart and in the blood vessels very well, and that's why we use it more than we use verapamil. Verapamil is more used if you have the tachycardias and what, but for better blood pressure control you can use diltiazem. But remember that sometimes they do combine the drug. It's not contraindicated absolutely. Like if you find a patient with resistant hypertension, you want to bring the pulse down, the heart down, and also the blood pressure, you can use it. Just remember that those are trick questions. Because in the past, we just think you cannot use both, but a few people have been used them. So then there are the other uses. I had to bring this up because you find that there's not much research which is done on calcium channel blockers. That's why we don't have many CMEs, and that's why I commend Ajanta for having remembered there's a group of drugs called the calcium channel blockers. Because most of the drugs are the novel, all the rest, the ACEs and all those inhibitors, but not this. But remember that the research which is being done is actually on other uses of these calcium channel blockers. For example, they're used apparently in treating the neuropsychiatric conditions like depression and mania. They're used in primary aldosteronism, in neuropathic pain because they stabilize the membranes. They've been found to be effective, and they're actually doing research in prevention of Alzheimer's disease, which you'd think about. You don't want your patients to get cognitive decline. All those patients, especially after the stroke, and even us wouldn't want to develop it. In migraines, and patients with anal fissures, because remember, a calcium channel blocker, the fact that you'll be relaxing the anus and also relaxing the esophagus in patients with the achalasia, they can be used, and also in treatment of high altitude pulmonary edema. So those are some of the novel uses. So because your patients, you could find have some of these. Also start taking note yourselves that what were the other benefits you're seeing, and then we can maybe discuss them in the next Ajanta, ACME session, that what was your observation among the patients who you had put on calcium channel blockers. So, so basically that was it for me, but I wanted us to make this very interactive, where you just tell us your different experiences, whether you still are happy with the calcium channel blockers, what are the gaps that you see, what can be improved. So yeah, but otherwise, thank you very much.
Thank you. Thank you very much. I know you have a lot of questions there. I would suggest that we go to the next presenter. And once this is done, then we can have a general Q&A session. What do you think? Okay. So in that case, Dr. Mutebi Idrisa.
Thank you, Dr. Barbara.
So thank you, Dr. Barbara, a round of
applause. For a nice presentation on CCB. And CCB is a widely prescribed in Africa and the most dependable antihypertensive. And Synod is a new generation. Thank you.
Thank you very much.
Thank you very much. Thank you, Dr.
So
Barbara.
we'll move to next presentation. I would like to invite Dr. Moses, a consultant physician from Kenya, to have a case study presentation on SGLT2 inhibitors in heart failure patient. So, Dr. Moses.
Yes, so as Dr. Moses is coming in, he is a physician from Kenya. He works in a company, in a hospital called Bungoma County Referral, where he runs a very busy diabetic clinic, seeing almost 40 patients per day. He has an MSc in endocrinology from University of New South Wales. So I'm sure he's very excited to be presenting for us today. Karibu sana, Dr. Moses.
Thank you so much for that kind introduction to the audience. Good morning once again. I wish to take you through one of my patients I happen to see in the clinic, whom I've been following up for the last 2 years. Sorry. Sorry for that. So she goes by the name Dio. She's a teacher by profession, 58 years old. She has had diabetes for the last 2 years, but initially before that, in the year 2014, she had pulmonary tuberculosis, which affected the upper left lobe, causing fibrosis and atelectasis. She has had hypertension since 2019, and the major medication she has been using is nifedipine and nebivolol. So when she was diagnosed with diabetes in February 2023, she was introduced on a combination of metformin with gliclazide. She's obese with a BMI of 32.4. On the clinical assessment, the blood pressure was elevated at 154 out of 116 and was a bit bradycardic at 56 beats per minute. The HbA1c was 11.7%, and at that time, the fasting blood glucose was 17.4. The lipid panel revealed a total cholesterol of 210, a low density lipoprotein of 4.5, triglycerides 167 with a high density lipoprotein at 52. The renal function, that is the estimated GFR, was at 87 mils per minute. The liver functions were normal, and the weight was at 85 kilograms. Maybe any questions before that?
Well, I think you have to risk stratify the patient because you have to put it in high risk, very high risk, extreme risk. What do you think is the risk here in this particular patient with hypertension and with, of course, diabetes, which is uncontrolled with dyslipidemia? So what's your risk scoring of this patient?
Okay, before I answer that, I think let me take you to the next slide on the evaluation of the heart. So the ECG done at that time revealed atrial fibrillation with a controlled ventricular response. Then the echo showed that she had an ejection of 42%. The left atrium was dilated and she was having atrial fibrillation, had a mild MR, and had this regional wall motion abnormality, basically affecting the septal wall and the inferior septal wall. So coming back to this patient, this is I will answer your question as per now. This is a very high risk patient. Already she's having atherosclerotic cardiovascular disease as evidenced by this ischemic heart disease that is most likely causing the atrial fibrillation. She already has dyslipidemia, and the glucose control is really bad, or she's poorly controlled, as much as that was done at the time of diagnosis. So on the possible diagnosis that this patient had, as I mentioned, she's obese with a BMI of 32.4. She has a reduced, that is heart failure with mid-range ejection fraction. Then she has ischemic heart disease with atrial fibrillation. She has, and then she has the existing hypertension, then the atelectasis that was present. I forgot to mention that also at that time she had hyperuricemia that was at 683 micromoles per liter. So on the management of the patient, this is what was done. Because of that a high HbA1c of 11.7, I stopped the gliclazide and the metformin combination and started the patient on a basal insulin at 10 international units in the evening. I introduced the patient to a combination of empagliflozin and a metformin, that is at 500. I dropped nifedipine for the obvious reason that Dr. Barbara said here, because we are having already heart failure. For the control of the hypertension, I started the patient on a combination of the neprilysin sacubitril, put the patient on an MRA, continued the beta blocker that she was using, that is nebivolol. Then I put the patient on anticoagulation, that is, I know I'm supposed to use warfarin, but I opted for the drug for simple reasons that the duration, the monitoring was going to be tricky in this patient because of the poor clinic, the long duration of the clinic that she has to come back. I introduced the patient on a statin, which she's using up to now, and also did, so the anticoagulation, it was more of a dual therapy, that is clopidogrel and the rivaroxaban. Currently, the patient is doing well. The repeat echo that was done somewhere in June this year showed that the ejection fraction had come to 45%. She weighs 75 kilograms. Of course, she's still obese, but has lost a bit of the weight. The HbA1c currently still stands at 6.2%, and she's doing pretty well. Thank you.
Thank you very much, Daktari, for that very nice presentation. As we had agreed, I think we'll move on to the last presentation, and then from there we can be able to sit down and be able to interrogate questions on all these three presentations.
Dr. Mutebi. Okay, yeah. Idris. Dr. Mutebi Idrisa is an endocrinologist and an epidemiologist from the source of the Nile. And he's at the National Referral Hospital in Mulago. And he also directs Wellington Diabetes and Heart Clinic. He's a member of the Uganda Diabetes Association and the Association of Physicians of Uganda. He's going to talk to us about integrating the 2025 guidelines into practice. The ones of American Diabetic Association, East African Diabetic Study Group, as well as the IDF approach. Dr. Mutebi.
Thank you very much. Karibuni. Musibye mutya olwaleero. Good afternoon to everyone. Sabah al-khair. Assalamu alaikum wa rahmatullahi wa barakatuh. So before you, it's a great day, and I would take this opportunity to thank Ajanta for this organization. Ajanta doesn't take anything for granted. I was with you in Spain, but you take particular interest in every detail. And I would concur with my colleagues that thanks very much for this organization. Thank you, Doctor. And also thank you. And thanks to the team that received us, the team from Egypt, the tour company, and everyone. Okay, and also the team who received us and who guided us through. Now, I'm going to be taking you through the 2025 guidelines. They're really very wide. We cannot compress all of them within such a short time. But I'll try to see what I can cover and to see what we can take home. How do we integrate this into care? Okay, at the end of the day, that is going to be my scope. We shall look a little bit into the statistics. As an epidemiologist, certainly I cannot go away without looking at statistics. Then we shall look at how we can integrate this into care, look into the pillars of diabetes care, and then how do we assess the different comorbidities, and take a little time to look into the SG blockers. And there's something new out there about calcium that we shall discuss at the end. WHO declared diabetes to be an epidemic, but also a pandemic. And I think this was as early as 2016. However, this year, the WHO called on to the UN member countries to come up with an urgent package to support control diabetes, because the numbers are just worrying. As you can see, we have almost close to 600 million people with diabetes, and that number is going to keep going higher. In Africa, this is currently around 25 million people, and that number is going to almost double over the next 25 years. So diabetes is with us, and it's really going to hit hard. Now, we look at diabetes in different areas, but generally, diabetes is a vascular disease. It's going to affect every system that has got blood vessels. It's going to affect your heart, it's going to affect your kidneys, it's going to affect the muscles, it's going to affect the bones. Currently, as we're going to discuss, diabetes is actually affecting the bones. So through the different pathways that diabetes causes, they all end up affecting the endothelium. That's why we know now that diabetes is an endothelial disease. It is a vascular disease. Now, diabetes does all that by damaging tissues. Nobody would be worried about diabetes, but it hits the vessels hard. Everywhere where we have vessels, we have as many as 36% of patients with coronary heart disease. We have, on the other extreme, neuropathies, 68%. And this picture is the same across, whether you're looking at high-income countries or you're looking at low-income countries. The damage the numbers are really worrying. There is hope. Certainly there is hope that once we can bring down the HbA1c, we can actually minimize the damage that is being created by diabetes. My colleague from Tanzania, Dr. Bwere, she said that the patient moved from HbA1c 8 to 7. Just a drop from 8 to 7 alone, that created a drop in the risks. Death from diabetes by 21%, heart attacks dropped by 14%, microvascular complications by 37%, peripheral vascular disease by 43%, just by a single drop in HbA1c. So let us look at this critically. We don't simply say, this patient HbA1c is 8 and then off you go. No, a slight drop in that HbA1c is going to give us good outcomes. The different organizations that are regulating diabetes care and guidelines, because of that increasing problem and the different guidelines which were coming out, they decided that they needed to have a harmonized approach to diabetes care. And so they came up with guidelines that are sort of like uniform across the board. But what is very important is that these guidelines should be patient-centered. Previously, we were focusing on what is the guidelines say on this, what is HB, a control over 3 months. But now, these guidelines are focusing, we should be emphasizing on this particular patient. You have a patient before you. How are you managing this patient in totality? How are you integrating the latest research? We know now that we have the continuous glucose monitors. How are you integrating all that into the care of our patients? And all of that has to be backed up by evidence. This is a very common pictorial, but very important, that as we address diabetes, we must lay everything at a base of lifestyle modification and education. We have our 4 major pillars thereafter: the glycemic control, blood pressure control, lipid management, and then the assessment of the cardiovascular and renal issues in these different patients. So we must have all those 4 pillars, but at the basis of lifestyle. Now, the new guidelines really emphasized the multi-sectoral approach. As you sit down in your clinic to look after these patients, how are you engaging the different sectors? The lab, the educators, the dietitians, the nutritionists, the exercise experts, the food care experts. There was a big call that the different sectors should be engaged so that we manage these patients better. And of course, what came out very strongly was the use of SGLT blockers because of their increased cardiovascular and renal benefit. Previously, remember, this was as early as 2018, we used to have this approach to our diabetes, where our starting point was, okay, let us use metformin, 3 months, no control. Let us move down to other drugs, maybe add on NSU, maybe add on pioglitazone, but that was then. Now, things have changed, and the new approach is really to look at this patient. For starters, when you get your patient into the clinic, you have got to risk stratify your patient, identify your problems. How is my cardiorenal? How is my diabetes? And that has got to be put in the context of weight control and then the diabetes control. So what came out very strongly is, what is my SVD risk? What is my risk score? How is my heart? How are my kidneys? As a very strong point right at the beginning as we begin treating these patients. Now, again, through those guidelines, you can see on the extreme Okay, so on the extreme left, you can see that once you have a CVD, then you want to bring in the SG blockers. And then if somebody has any indication that they have a high risk, just like the patient, my colleague from Dr. Moses presented, that patient had a high risk. So you want to quickly use the SG2 blockers or the GLP-1 agonists because of their benefit. And if there is no benefit, if there is no response after 3 months, then you may want to include another group which you didn't start with. For example, you started with the GLP, then you can add on the SG. And then on the other side, as you move on the other side, if you have cardiac failure or if you have a CKD, then still you want to start your SG blockers as early as possible because of their proven benefit. However, you always have to keep an eye on your GFR. How far is your GFR as you manage these patients? The guidelines also emphasized we have to look at the liver. Previously, we had what we call the NAFLD, non-alcoholic fatty liver disease. Now it is called metabolic associated cytotic liver disease. Then we had NASH, which is now called MASH. Now those, the SG blockers and the GLPs have got an effect also on those liver issues. But also, because of this total engagement of our patients, we have to look into other organs, see how they're doing. And then on the other side, again, they try to stratify how much glycemic control you're going to get given your drugs. For example, you can see the high efficacious drugs like the GL blockers, and then you have the SG blockers, and then you have the DPP4 inhibitors. And then on the other side, you have the different drugs that can support you in terms of weight, right from the GLPs and all the way to the SG blockers, and then the metformins, which are weight neutral. Now, those have got to be incorporated as you manage your patient. You have to keep an eye on the different domains. How is my cardiovascular risk? How are my kidneys? How is my cardiac failure in this setting of weight and glycemic control? Of course, WHO introduces more other things into this. How is the cost? How is affordability? How is access? How are the side effects? Those have got to be also put into the picture. I think my colleagues have gone through this hypertension. Somebody asked about whether there was a dual usage of drugs in hypertension. So what do we know about control of the, hypertension in these patients? If you have blood pressure of more than 130 but less than 150, then you're going to use a single agent. If you have the blood pressure above 150 over 90, then you're going to use a double agent. Remember in that patient by Dr. Beira, that patient had a pressure which was between 130 and 150. So a single agent can support you in there. However, if you have got CAD or you have microalbuminuria, then you're going to introduce the S inhibitors. They're going to support you in that context over other antihypertensives. And then on the other side, again, once you have renal issues, then on top of your two drugs, one of them should be an S inhibitor. And then you monitor these patients, and if you have no response, then you keep adding on other drugs. Okay? And as you can see, way down, consider addition. If you look down, you can see addition of the MA receptor antagonists if you have no response on the above two. So the MAs are coming after the initial group. The initial group has the inhibitors, ARB, the CCB, and the diuretics. However, just like we said, this has got to be individualized. If your patient, you feel they can benefit, then you can bring those earlier. Lipid control. Primary, remember primary, we don't have any event happening. You have to look at the age. Okay, 20 to 39, consider a statin. If you're between 40 to 75, you have diabetes. Then there you want to use a moderate intensity statin. If you are more than 75, then you have to weigh the benefit vis-a-vis the risk. So any diabetic who is between 40 to 75, you want to keep them on a moderate statin. Okay, certainly if you have got an event, you need the high intensity statins. So for example, if you have had an AMI or you have any event, certainly you need a statin. Okay, I'll skip through that. Okay, now when we go to the kidneys, very important, you have to clearly define what are my problems. How is my heart? How is my kidney? How is my control? Well in time as you manage these patients. And of course, don't forget, good health is good for the kidneys, physical activity, you have to stop smoking, weight control, but also the medicines. We have to look out for the different medicines which can affect the kidneys. Hydration, very important within these patients. And how you manage them depends on what problem you have. Is it a problem with the heart? We have talked about that. If it's a problem with microalbuminuria alone, okay? And the different steps take you through the different drugs which you consider given the problem you have. Is it a problem with CVD? Then you have a track for that. In the interest of time, I'm just going to fly through these. Okay, now we get down to the SG blockers. Very important for us to remember that the body doesn't want to lose precious material. Glucose is a precious material. So the kidneys always try to reabsorb. The SG blockers are going to tell the kidney, hey, we don't need this guy is causing trouble, and they're going to cause an excretion. There are different studies which have supported use of SG blockers, and in your free time you can go and look at each of those different studies. The one which interested me a lot was the Credence study. That study was stopped midway before it ended because of the overwhelming benefit, causing a reduction of almost 30% in renal performance. DAPA-CKD, EMPA-KIDNEY, all those were having tremendous benefit of the SGs. So the different studies are showing the benefit of the SG blockers in the heart, in sugar control, in the kidneys, in the weight, and the different bodies have really approved SG blockers to be used across the board, even in patients who don't have diabetes. They have benefit to the heart, they have benefit to the kidney, they have benefit to the weight. So because of the tremendous benefit, there has been a unanimous decision that these agents should be used in those different modalities. Very important to note that in all forms of cardiac failure, they can be used because they reduce death, they reduce hospitalization. Again, this is to emphasize the same point. This is by FDA approving the same SG blockers. Really, these were different graphs to try and look at the benefit across the different forms. For starters, what is the benefit of the SG blockers in terms of glucose control? If you use 2.5, 5, and 10 of dapagliflozin. The 10 is the one in blue, and if you see the drop in A1C, the blue one was going all the way down compared to placebo or any of the other types. Remember, red, yellow, blue. You know, in my country, those colors are very significant. They have nothing to do with anything else other than the I see that the yellow was performing better than the red. Okay, again now, effect on fasting blood sugar. You can see that they're performing better than placebo. Now, a little bit into the epidemiology, if you see those the error bars overlapping, it shows there's no significance. But you can see the blue and the yellow were more or less working almost, giving us the same effects. So again, this is to emphasize the benefit in fasting blood sugar. What about in weight? Again, you can see the yellow, red, and blue were performing better than the placebo. Now, these are different graphs to show us how the SGs were performing vis-a-vis placebo. Number one, in terms of the overall primary composite outcome, you can see that the cumulative incidence was less in the DAPA group. The other one was renal outcomes. The blue was performing better than the red in terms of the renal outcomes. This was death from cardiovascular events or hospitalization, death from all causes. So all these were really to put even extra emphasis on the benefit of dapagliflozin vis-a-vis placebos. Now, this was a very interesting study where they looked at us starting the SG blockers earlier on rather than waiting. If you remember, there's what we call the legacy effect, okay, or metabolic memory. The same happens to when we start the SG blockers. This graph is showing us at some point, person who is 70 years, but the kidneys are way off, and down is somebody who is 70 years, and the kidneys are off in terms of performance. The number of years you're going to get the benefit is less when you start late. So the lower graph, you can see you're only improving this person's life by 3 years. The top person where you started when the GFR is at 70, You're improving their life by 11 years. So again, this emphasizes we must have good control, start the beneficial drugs well in time, because the body has that memory. If you start late, it's not going to help. The body still has that memory of poor performance. Again, to summarize, what is the way forward? Personalized care. Let us look before the patient before us. Let us have clear evidence, and the evidence is overwhelming about the benefit of the different modalities. Let us have multiple goals. What is our goal? Are we looking at the kidneys, the heart, the sugar control, the lipids, the BP control? Are you looking at the liver? Are you looking at the eyes? Are you looking at the different modalities? And then technology. This has got to be backed. We must adopt new methods. Now we are talking about the continuous glucose monitors. Of course, the costs are still high, but over time, we should be incorporating those into our care, and then the multi-professional care. If I'm looking after a patient, there's no harm in me calling Dr. Assad and say, Dr. Assad, Dr. Barbara, Dr. Sekasan, this patient I'm sending to you, you're going to be looking after them. The kidneys or the heart is not performing well. So inter-professional involvement. As I wind up, very important study that I came across, where we are faced by yet another problem. We have diabetes. Vitamin D has been found to have an association with diabetes. Hypo levels of vitamin D worsen your diabetes. But also, diabetes has got a linkage with osteoporosis. Now, this is even worse with ladies who are going into menopause. 200 million ladies have got this problem worldwide, and this is a huge problem which is even going higher more than some of those cancers. This causes bone fractures and disabilities, and the bones have got DPP4, and the DPP4, what it does is stimulates osteoclastic activity in the bones. So because of that background, there was a thinking that if we use DPP4 inhibitors, they can block the osteoclastic activity and promote osteoblastic activity. And a study was conducted looking at sitagliptin and looking at ladies' outcome among women over 52 weeks. And this was a multi-centered study, a superiority study, blinded, placebo-controlled, and this was conducted in patients with diabetes who were on metformin and were stable on glucose control, so that they didn't run into ethical issues. And they monitored the bone density of the ladies before and then after 52 weeks. And they came up with all these findings. But what is very important to note within this slowdown trial is that sitagliptin significantly reduced the bone demineralization within these ladies. So what are we saying is that we are going to see even more benefit of the DPP4 inhibitors in terms of osteoporosis, particularly in which is a big problem within the ladies. For those of you who are interested in statistics, you can see where we have that red block. You can see the p-value was less than 0.05 as you look at sitagliptin vis-a-vis the placebo changes in bone density. So treatment with sitagliptin preserved the bone density, and there was a significant difference between sitagliptin and the placebo. Okay, thank you very much.
Thank you, Doctor. Excellent. We got the 2 clues for this presentation for our next decode program. There is your last 3 slides, which is going to be next decode, sir. Because it is wonderful. You have talked beyond the diabetes. You have talked beyond the endocrinology. You are great today. Thank you.
Thank you very much, Dr. Mutebi, for also keeping within time. Now we are going to have a Q&A, and I would request our Senior Professor Adele to preside over the next part of the presentation, which is the Q&A. So I know you have a lot of questions out there, and we should do straight away kickstart this. Maybe I can start. I'll ask Dr. Moses two questions. The first one, you gave your patient a dose of a basal insulin of 10 units. And I wonder whether that was an adequate dose for that patient. The second thing is, a lot of times we talk about diabetic control and management, and we don't seem to emphasize nutritional intervention in our patients. I don't know how easy it is in Kenya, especially to advise patients on diabetic diet. In Uganda, we seem to have problems because a lot of our diet is loaded with carbohydrates, ugali, viazi, matoke, this kind of food. I don't know what sort of challenges you face there.
Okay, thank you, Mr. Chairman. Again, I am very honored to have you from Kenya and Uganda and Rwanda. It's very unfortunate that the group from Tanzania wouldn't make it. Maybe we can meet in another meeting. Actually, to have your attendance is very important, and I'm talking about the diabetes and hypertension in Africa. I tried to get some statistics for you, and I'll show you some of the statistics of hypertension in Egypt. And we'll try to show you what are the problems in Africa, especially Central Africa. And I hope this will shed some light on what we can do for the future of our patients in Africa. So Africa stands at a critical crossroad because two interlinked situations of hypertension and diabetes are there and are silently reshaping the continent's health landscape. Actually, I call them double jeopardy or double trouble if we have diabetes and hypertension. These are the varying prevalences of diabetes and hypertension across African region, and you can see here the colors, the darker colors are the ones with the highest instance of the higher disease burden, and Central and Southern Africa show particularly elevated rates. And the diabetes epidemic in Africa represents one of the fastest growing health crisis in the world. Africa experiences exponential growth that shows no signs of slowing, and actually there are projected about 28 million patients of diabetes and 63 million of pre-diabetics, and the growth rate is huge, it's 90%. In Egypt, for example, Egypt is number 11 in the world with the population, not the percentage, it's about 11%, and is expected to reach 12 million Egyptian patients with diabetes. For hypertension, it's a silent killer, we all know, and it's the first cause of premature death or even sudden death. 27% average prevalence of hypertension in Africa, and the combination of high prevalence and low awareness rates particularly insidious. And you can see here, we had a very great project in Egypt called 100 Million Wellness Project. In this project, about 50 million Egyptians were examined in different clinics, outpatient clinics, for hypertension, for blood glucose, and for risk factors. And we can see here that hypertension represents about 29.5% of the population as a whole, and 84% of total deaths are caused by 4 main non-communicable diseases, the most important of which is hypertension. And you can see now even the raised blood glucose level reaching 15.5%. And the fact is that they don't come alone. Hypertension awareness in Egypt is about 38% according to the latest WHO criteria. The number treated are only 24%, and the control rate is down to 8%. So there is a missing information and missing treatment in such patients. And hypertension does not come alone, and about 76% of hypertensives have combined diabetes. So, is there an economic burden of this? Yes, there is an economic burden for whole Africa, and this is the $25 billion loss of economic loss estimated yearly for cost of diabetes and hypertension through healthcare expenses and lost productivity. 15 to 20 years of life is lost from this combination, and to 2 to 5% GDP impact on the impact of GDPs along the African countries. The double burden, why it does like this, when diabetes and hypertension combine, because of about 58% of diabetics are hypertensives, when they combine, they don't simply add, they multiply. So whenever you have diabetes and hypertension, then you have double trouble. Why? The pathophysiology behind this synergy is complex. High blood sugar, we know, will damage the blood vessel, and hypertension will also cause shear stress to the walls, so it accelerates atherosclerosis, and this is a vicious circle. If they combine, we have very diseased arteries all over the body. Heart attacks increase by 2 to 4 times. Strokes, combined conditions create severe vascular damage and leading to both ischemic and hemorrhagic strokes. Kidney failure, and we have nephrologists here, and the dual pathology accelerates chronic kidney disease, often requiring dialysis. Vision loss, we know retinopathies and what happens, and peripheral vascular disease, which is very common with coronary artery disease. So we have 1 in 4 patients are adults with hypertension in Africa, and 1 in 17 adults with diabetes in Africa. And this translates into millions of individuals. What are the drivers of this epidemic? Could be urbanization, lifestyle change, and socioeconomic factors. I'll try shortly to show what's happening in urbanization. You know, there is rapid nutrition transitions, and we are facing now from the traditional vegetables and refined carbohydrates to very high carbohydrates diets and Western diet. And this is a real problem of urbanization. The salt intake in processed foods and fast food contains excessive sodium, driving blood pressure upwards. And the estimated in Egyptian patients, in individuals, 9 grams of salts of sodium are digested every day. So this is a big amount. Fat quality, traditional healthy fats replaced by trans fats and saturated fats in fried and processed foods of Kentucky and whatever. Portion sizes are increasing. We are going to fast food, Western style large portions, replace the traditional eating patterns. So this was a very interesting study on an African university students. These are the age of 18 to 25, which is a very young age. And astonishingly enough, 26% of these very young population has hypertension, and 21% are classified as obese. This is a real problem in very young population from 18 to 25. The common risk factors, sedentary behavior, they are all sitting, studying all the time, no exercises, nothing. Fast food consumption for young generation, and alcohol use. Smoking is still an issue in Africa, and still a big issue in Egypt. Sleep deprivation is one of the main causes of hypertension. Stress with the academic and financial pressures, elevated cholesterol and blood pressure. About the socioeconomic factors, So with the poverty, there are limited resources between healthcare and other necessities, so they neglect treatment and start looking for food and diet. Healthcare access is difficult in rural areas in most of African nations, and health literacy with low education levels and limited health knowledge impair prevention and early detection, which is the key of our aim message in management of diseases, is to try to prevent rather than try to treat. Historically, cardiometabolic diseases were considered urban problems because of the way of diet and things like that, and the rural areas were supposed to be the healthy areas. But with improved road networks, TV and social media, motorcycle transport replacing walking, cash crop farming replacing diverse substance agriculture, all these are moving rural to urban. They are not really rural anymore. They are all urban habits. Beyond lifestyle factors, African population has important metabolic differences that help explain disease patterns. Maybe some genetic deformities or whatever genetic peculiarities. Higher visceral adiposity in Africans, greater insulin resistance, salt sensitivity. With each salt, they have high salt sensitivity. More endothelial functions has been proven in African patients, and difference in inflammatory pathways may accelerate atherosclerosis and complicate diabetic management. So there are healthcare system limitations. We can discuss this later on, but there are structural barriers and there are workforce challenges. Not many doctors everywhere, and subspecialties are rare. Endocrinologists, even in Egypt, are not a big number. I mean, you can find thousands of GPs, but you will find only hundreds of endocrinologists. And the same for nephrologists. Not for cardiologists, really. We have too many cardiologists, I must say. The structural barriers include healthcare system limitation, and you can see here are the rates of control of hypertension among Africa, and even in Egypt, as I show you, it was 80%. So it's less than 10% in men and 13% in women. So the structural barriers were because actually all African centers were directed toward epidemic diseases and fever diseases and infectious diseases rather than dealing with the core of problems of healthcare in African patients like hypertension, diabetes, dyslipidemia, and these are the main barrier because the acute care models were not directed for cardiac and diabetic patients, were directed for more disease in fever diseases. The vertical programs, disease specific like HIV, TB, malaria, that don't integrate chronic care, and there are weak primary care facilities in most of the parts of Africa. Urban concentration is mainly in the healthcare system in urban areas rather than in rural areas. So you have to travel or fly for long distance to have proper physical care. Equipment shortage, which is a problem everywhere. You cannot find all the equipments you need and all the medications you need and everywhere. Of course, also because of economic problems, most of the doctors try to flee to abroad, so have better wages, better lifestyle. So migration of trained health professionals to high-income countries is a real problem. Last year in Egypt, for example, 10,000 doctors left the country. Thousands were to England because now in Britain the regulations are less strict than other areas. They have deficiency in doctors and they accept doctors from everywhere. So about now, even you can see the flights full of Egyptian doctors going to London. Insufficient training, which is a problem, and we are responsible for that. The cooperation can lead to more training of doctors everywhere. And also, doctor to patient ratios are very low in most of the cities and most of the towns of Africa. And of course, the workforce challenges also. Not all doctors want to work in rural areas. They want to work in the central areas, in the city, in the capital. So they leave the rural areas unattended or limited specialties there. And of course, this will lead to burnout of doctors. And there has been a lot of studies on burnout doctors working too many hours, extra shifts, and burnout doctors cannot perform properly and they are always under stress. So it's time for action and innovative strategies, and I'll show you one of these programs. It's called the Linked Hearts Program, and it's offer a new paradigm in chronic disease management for resource-limited settings. The program components is the community health workers, trained by health workers, and it involves home blood pressure monitoring, patients receiving validated home blood pressure and training on proper measurement techniques, and home glucose monitoring. Diabetic patients learn self-monitoring of blood glucose to guide treatment adjustments. The program components like mobile health applications, smartphone applications, and task shifting protocols leading to more nurse care in the clinics and the outpatients rather than doctor care, and the doctor will be involved only if there is a complication. For example, for management of hypertension, once you receive the proper medication, your blood pressure is fine, your follow-up in the clinic will be by the nurses. They measure the pressure. If they are okay, it's fine. Don't burn out your doctors by unnecessary work. And the team-based care models, of course, does not include only physicians, but nurses, pharmacists, and community and health workers. The team-based core models will improve the control rates because you will train properly the nurses and the pharmacists and the physicians. And this will improve adherence, which is usually traditionally between 30 to 40% of up to 60 to 70%, and adherence is the cornerstone of proper management of any disease. If you adhere to your medication, your control will be better, and of course will reduce complications. So there are some suggested mobile health technologies, include SMS medication reminders for the patients, educational messaging stating some facts about diet, some facts about the risks of hypertension, all in messaging, and appointment reminders for the next follow-up of the patient. And suggested mobile health technologies also. Mobile health technology is very important, like home monitoring support, teleconsultation, and peer support platforms. With teleconsultation, during the COVID period, we had this experience that most of us were not facing directly the patient. We were facing either by, telephone calls, maybe virtual meetings to treat the patients by phone or by virtual meeting rather than direct. And this will be important in follow-up of patients in different far away or remote areas. The patient doesn't have to fly to 300 or 400 kilometers to come to you, to their clinic. If they are only for follow-up, they can see them visually. So international cooperation is the answer, and no African country can tackle cardiometabolic disease alone. The challenges are too long, the resource equipments too substantial, and the expertise too specialized. International collaboration between African governments, non-governmental NGOs, multilateral health agencies, research institutions, and private sector partners is essential for success. And Egypt is actually actively involved in training and education for African physicians and African doctors. And we are happy to receive any African candidates that are willing to have more knowledge and more courses. Egypt is ready for this. And effective collaboration to assure shared decision-making for our real problems. And I have a quote from Mamdani, if you allow me, after his win in New York. is that Egypt is an African country, it's an Arab country, and it's a Middle Eastern country. And I will not apologize for any of these, okay? Okay, so it's called for action, and what could be done is to equip clinics with diagnostic tools, deploy and train personnel, ensure medication availability, and this is your duty, Ajanta, and expand community health worker programs and invest in mobile health solutions like SMS, whatever messaging appointments, and remote monitoring system of blood pressure and blood glucose. So my takeaway message is that twin epidemics require integrated approach. Early detection is critical, and this is important. Lifestyle change is fundamental and foundational, and I think this is the training and the teaching of the population is important, and community engagement is essential. Technology offers scalable solutions. Health systems must transform, and success requires partnership. So together we can tackle diabetes and hypertension for a healthier Africa. Thank you. I just want to add something, and I'm really again happy to have you here. And I think after the discussions, we can give the certificates and everything. Okay, I saw it. It's very fancy. I mean, I saw the. Yeah. So if there are any questions about the previous talks or any suggestions for the future cooperations, you can. Yeah.
Thank you. Dr. Jakait is my name. Thank you very much for inviting us here, and that was a very good presentation, especially what you've just said, for the overall well-being of our people as far as diabetes, hypertension, and healthcare is concerned. A quick one. Dr. Mutebi mentioned something about statins and those patients who are over 70 years. And it has been bothering me, specifically in terms of guidelines. If you are over 70 years, diabetic, hypertensive, your lipid profile is normal, your blood pressure is within target, your diabetes HB control is also within target, what's the advice as far as statins are concerned?
The problem with the age is that the longer you live, the more the risk of having heart attacks and of having strokes. So I think statin is needed in every age, but with different dosing. And I don't know if there is a different answer.
Maybe I don't want him to clarify the issue of, he said, caution.
Yeah, okay. You can use lower doses.
Thank you very much. Just a brief interruption. I want to welcome the people who presented to please have a seat over there, so that as we direct the questions, we know who we are directing them to. So, Daktari, please just have a seat. Dr. Barbara, please have a seat over there. Dr. Mutebi. Yes, Karibuni. So now we can ask them the questions, and then we can know who we are talking to. So please proceed with the answer.
My colleague from Kenya. Okay, now, just like we said, that as we are treating the patients, we have to individualize the care. Now, if you remember, we had those who were 20 to 40, then 40 to 79, and then those above 70 years. Now, the ones who are between 40 to 75, those certainly with diabetes, they need a statin. Now, those who are above 75, you're supposed to factor in because they could be having something else that could hinder. Remember, the statins on the other side, they can cause issues on the muscles. You may have, so you have to, yes, they should be on the statins, but you have to keep an eye onto the effects, the other side, the negative side. So that's why the guidelines are telling you that, fine, give the statins, but keep an extra eye on this particular group of patients. But certainly, as you get older, remember age alone is a risk for CVDs as you age. Dr. Raymond, I think, wants to throw in something.
Benefits other than lipid lowering, when you use statins, are there other benefits other than lipid lowering?
Okay. Now,
because you talk of plaque stabilization, does it reduce the plaque? Even if is there other benefits? I think that's where his question is coming from.
Now,
and then actually, in your presentation, I think you had two sides. It is prevention. I think you had statins in primary prevention, and then statins used when the risk is high. Using statins when there's no risk, using statins when the risk is very high.
Yes. Certainly, just like you see the SG blockers, the statins, other than lipid lowering, they have so much benefit across the board. They are supporting your endothelium, they have got some antioxidant property, so they have really extra benefits that certainly they will help you with. But just remember, the category we're talking about is the ones that are under primary. Secondly, certainly if you have secondary, you're going to need the statins, but this is particularly under primary. You don't have any event, but you're in that category, primary prevention. But certainly the statins have far more benefit than just lipid lowering. So it emphasizes again the point that these patients would certainly benefit, and I'm sure you've read studies that have demonstrated that even patients with normal lipids, if you put them on statins, they benefit better than patients who are not on statins with normal lipid levels. Now that emphasizes that these lipids are not only giving us lipid lowering, there are other benefits that they are offering these patients, antioxidant properties and others.
Sorry, on top of that, remember these days, especially in those who have risk, and being elderly is already a risk factor, we want the lipids to be as low as 70. Remember, so you find most of the patients, of the elderly people have about 110, 120, so the lower they say the better. But of course there's the extreme end where they get more side effects, the pill burden, if they're already on statins. These are patients, as you grow older, because like most of the drugs are affected by the fast pass, the CYP, metabolism and all that. So yes, we have to be worried, but remember the lower the lipid level, the better, unless they get side effects, especially like the tummy effects, because they have that as well. So I would agree that the lower, the better, even for the elderly, unless it's another contraindication.
All right. My question is, am I hijacking? Sorry, no, you go first.
Go first.
No, go first.
Okay. Dennis Mugalu, and my question goes to Dr. Barbara.
Yes.
Thank you for the recap on the calcium metabolism and physiology. It took me far back, but it helped me a lot in understanding what you were delivering. My question goes on the aspect where we've always heard about the differential emphasis of the roles of, especially DHPs, CCBs in the management of hypertension, black hypertension vis-a-vis white hypertension. Is it something you caught wind upon, or is a medical rumor?
No, it's actually very true. One of the advantages of actually using calcium channel blockers, one, very good in blacks, because number two, they are not related to self, it's to salt intake. They are very good in almost every cause of hypertension, because even you had that primary aldosteronism, which is one of the commonest causes of resistant hypertension and secondary hypertension. It's one of the drugs there. Young people, because from the age of 6 years until elderly, you can use it. Great advantage because it's the fact that it's through the liver, metabolism is through the liver. So safe in patients who have weak kidneys, basically. You're not so worried about it. Even in patients on dialysis, it's not most of the calcium channel blockers are not dialysable, so you can continue using them. Basically, there is no reason why you would not use the calcium channel blockers for the most of the patients you're saying. Blacks, very, very good, because we found that they're more effective in black and even elderly people. So there's no reason why. So it's true what you're saying. Good for young, good for blacks. It was actually evidence-based, and also good in patients who are at risk for the other organ dysfunction, yes.
Well, a follow-up question on that. Is it something on the levels of genetic variations for the receptors, the voltage-gated channels you were talking about, or the mechanisms not well clear and be understood?
It's not really clearly understood, but remember, genetically, the RAS, somehow there's a difference in salt sensitivity, there's a difference in RAS between the Africans and the non-black, basically the Caucasian. So it's something that is more of genetic, yes, but it most likely has to do with the RAS. The RAS and the calcium channel system are very related. Actually, they're also interrelated genetically, especially in the kidneys. So it was actually found that the effect, the best effect on calcium channel blockers is those who have the weakest RAS. So the more you block the RAS, the more effective the calcium channel blockers will be. So that was scientifically proven, yes.
Thank you very much. My questions are quite wide. Forgive me that I'll even shoot the chairs because they are authorities in this. My first question is, Dr. Barbara, we've seen patients who are being given nimodipine and amlodipine at the same time. Patient has a subdural, they're on nimodipine, but they're hypertensive and their pressures are not coming down.
Sorry, that one, they don't do that. Those are errors. But that was just an error, don't even.
Thank you very much. The second one is the maximum dose of amlodipine. I've seen a 20 written somewhere. I don't know whether it has changed. These are open questions.
The maximum dose has actually been 10 milligrams in most cases, but at least with cilnidipine, you go up to 20 milligrams, and it has been found to be better at blood pressure control. In fact, for patients who you find have resistant on the 10 milligrams of amlodipine, try and go to a drug like cilnidipine. One, you can give it twice a day, or you can even just give it once a day at 20 milligram max.
You've been telepathic. That had been my next question.
Yes.
But my other question is, why is amlodipine not given 5 milligrams, for example, 5 BD? Why is it an OD drug?
Because it's so strong that the way it binds and bonds onto the receptors, it has a very, very long half-life compared to the nifedipines. So basically it's just about how long it binds and also the half-life and degradation. Yeah.
My last question to you is on S-amlodipine. The S-amlodipine, I'm told the maximum dose is 5 milligrams compared to the regular amlodipine, which is 10.
Yes, the maximum dose should be 5, but sometimes in some patients we've actually used 10 milligrams of the S-amlodipine. And without worrying, it has been actually effective. There's just a light increase. So most of the pharmacists fear actually to give the 10 milligrams, but you can convince them, if you just tell them that we are the specialists without using them, we've seen that it's actually better. There's no edema. But because we were worried about the edema that time, but remember now cilnidipine has come. So instead of worrying them and saying, they're telling you, no, we're giving 10 of the Asomex or S-amlodipine, you can just now go to cilnidipine instead without worrying the pharmacist.
The last question is, have you come across SLE-like flares with especially the drugs like diltiazem, and how often it happens?
That's why I put it on the slide, that one of the side effects could be the skin rash. I can honestly tell you I haven't, but I know it occurs in less than 1%. It can cause any type, including Stephen Jones. It can be really bad. Even eczema can happen. Psoriasis, actually, that's one of the one which I've seen for sure is I've got a patient who was a nightmare to treat because the patient had psoriasis, very bad pressures. In fact, she got annoyed with me because literally every drug, each time we try to give a drug, even just amlodipine, the ASs, she'd get the flares. So yes, I've seen more of the psoriasis than I've seen the other skin rashes, but you have to remember that it's possible they can get the skin rash. But just send them to the dermatologist to do their work.
Now I switch guns to Dr. Idris, and I think this one will also go to, not so much to Dr. Idris, but to Dr. Sekasamvu. There's been a talk about, the cutoff of EGFR in SGLT2s, but what I've seen is that most of the patients who are involved when they are making these cutoffs were diabetic patients. And there are now new studies which are coming up, I think one recently in 2025 in Taiwan, where they are recommending using SGLT2s irrespective of the EGFR, provided it's for cardiac reasons. The previous science was that when the kidneys have gone down to an EGFR of less than 10, you don't have any nephrons to work on. But then they are also recognizing alternative pathways for SGLT2s, especially in heart failure. So my question, because expert opinion makes guidelines, in your expert opinion, do you think that SGLT2s can be used irrespective of EGFR, provided we are looking at it in heart failure senses, as opposed to kidney disease, because that's for kidney disease? But two, there are studies that are talking about using SGLT2s in stage 5, and some patients who are pre-dialysis or on dialysis, that it's starting to reverse some of them back to maybe stage 3 and giving them another year or so of dialysis. Is that something we should think about, or are we hallucinating? Thank you.
I'll take a go at that. SG blockers, very good drugs. They have a very good property, is that they give us glucose wasting. Now, so with glucose wasting, we get all these benefits that come along. Okay, even in patients without diabetes, they can give you benefit on the heart, they have benefit in the kidneys, they have benefits all over on weight and everything. However, for any new chemical, it is always very important to be guided by science. So currently the guidelines we have is that you have to keep the GFR at the back of your mind. You don't want to use them if you drop below 20. And then number 2 is that you have to be cautious if somebody has got type 1 diabetes. They are contraindicated. I've received patients who are type 1 diabetics, they are put on SGs, and you really run into trouble. Those patients can go into DKA. So you want to be careful, but Dr. Sekasamvu can as an expert in nephrology, can add on to that. But as if a single study has brought benefit, usually under guidelines, they usually want to get a number of studies coming up. Repeatability and reproducibility is key before they put out any changes here and there. So a single study, if they find something positive, I'm sure studies elsewhere have found something on the contrary. So the governing bodies have to put all these studies together so that now they give us a common direction. As per now, the guidelines are still, we have to keep the GFR in check.
Thank you very much for that question. When you talk about renal effects of the drugs, or advantages of using SG inhibitors, it goes back to the basic question and the basic science that the human body is interlinked. The physiology is complex. And every day we learn new things about the human body. I think we know very little. But in the recent years, there have been associations between organs and disease. That's why we have the hepatorenal syndromes, cardiorenal syndromes, which are now being recognized as separate entities of disease. Now, when you look at renal and cardiac disease, those two are twins and closely related. And a lot of the renal disease that we see comes from cardiovascular disease and vice versa. And we as nephrologists, we know that the biggest cause of mortality and morbidity in our patients is cardiovascular disease. So when you use a drug that has got cardiac advantage, it will always give you advantage in renal disease. The SGLT2 inhibitors, they cause diuresis, natriuresis, and of course they reduce volume overload. They give a lot of cardiovascular advantages, and therefore would be useful through those pathways other than the direct effect on the kidneys. So even if the GFR would go down, normally the pathology would be on the glomeruli, on the glomerular tuft. So as long as the tubules can still give you function, and that is when your patient is passing urine, there's a potential advantage that these drugs would be good, even in patients with advanced renal failure, as long as they are passing urine. And normally we would talk about a basic of an average adult passing 1 liter of urine. So if you quantify and they are passing 1 liter of urine, you are likely to get advantage out of these drugs. Probably that's a short answer I can give you to your question.
Yes. Thank you, members. Mine's just a contribution to again the diabetes and then the statins and the lipid kind of situation. So there's the cutoffs for diabetes even lower for a normal person. So because the targets are lower and then versus the statins like Dr. Mtevi was talking about, be cautious. We have combination therapies these days. So you think about adding the ZMIBs or the fibrates in order to reach your targets for someone with high risk factors and most especially diabetic, so that you minimize the side effects of statins. So we have not yet, I think in Africa, Uganda, we have not yet seen the PCSK9 inhibitors, the injectables, but what I know is that they will come on board, but really let's try to achieve the targets in patients who are diabetics, and most especially if you had even hypertension, because the targets are even lower than the normal targets which people think of. Thank you.
So just a comment on that. The injectables are actually there, but it's because the Repatha, but because of the price. I know when they had first come in, that was in 2020, the injection was going at almost 7 million, which did not make sense. So we preferred to use the other type of drugs.
Thank you, presenters. Thank you, Moses, for the case presentation. Just by eyeballing, your patient looked to be at a high risk, but I'm interested in knowing which risk score did you apply, given the fact that most of these risk scores have been validated in other countries. And okay, since it was high, or assuming it was high, I saw you had your patient on echo had regional wall motion abnormalities. If resources were at your disposal, is this a patient you would refer for coronary angio? Thank you.
Okay, thank you for that question. I'll start by answering the first question about the insulin dosage, that is Elantas. I used 0.1 to 0.2. Initially, as a patient on 15, but she ran some hypos, especially the fasting. That is why I dropped it to 10. At our clinic that we usually hold twice weekly, a nutritionist usually on standby. She's the one to take the weights, calculate the BMIs, and she interacts with those patients daily. So I think it was just an overlook, but all those patients pass through the lifestyle modification measures accordingly. Now to your question, This patient has had an event already, that is a ischemic heart disease. So she's is not even at risk. She has the risk already. Okay, I didn't apply any scoring system in this patient, keeping in mind that she has already had an event that has happened, that is ischemic heart disease. I agree with you. If I was in a setting that I can do a PCI or a coronary angio, not a PCI, a coronary angio is a suitable candidate, especially looking at those areas of the walls that have been affected. So I'll send the patient for a coronary angio. Thank you. And maybe before I finish, maybe I have a question to Dr. Mutebi concerning my case. This patient was overweight with a BMI of around 32. Has had already a atherosclerotic cardiovascular event. My initial choice was the use of the insulin. We'll have done a GLP and combined with an SG2 inhibitor. Thank you.
Okay, thank you very much. I just remembered something, that your patient was female, and the patient, Dr. Baggy, sorry, is that how they pronounce the name? Berry. Okay, Dr. Berry. Now, those were both ladies, postmenopausal. So somewhere we have to keep a watch on the calcium. Dr. Babu emphasized the calcium. Once it goes up, we are in trouble. It goes down, we're in trouble. When it is down, super excitability in the body, in the muscles everywhere. Goes high, you start having all these, calcium forming clumps all over the place. In the urine, everywhere, your pressures are going to be in trouble. So, calcium within those patients. Now, your patient, you said, had an event, and if you see the age 58, that means that patient needed a high intensity statin, because you already have an event, already the age bracket with diabetes puts us that we must have a statin. But now that we have an event, we must start a high intensity statin, and our target is to get above 50% drop in the LDL as our target, just like Dr. Majwara was emphasizing. If we didn't have an event and it was primary prevention, then our target would have been a drop of 30% in the LDL. Combining drugs, certainly this patient putting a SG blocker certainly would benefit. As far as I remember, our renal function was normal in your patient. So certainly SG would benefit, because this patient had high blood pressure, had a hyperuricemia, and had a HbA1c was 11.7. So really there was a cardiac event. So SG certainly would benefit this patient, and it was very important starting insulin in this patient. But somebody, I think, had asked about the insulin, because you had started insulin, I think, was it 10? Basal. But again, just like we said, there are guidelines, but you also have this patient before you. I remember your patient was coming from far. Ideally, if you're starting insulin, you have to go through those steps. You start slowly, then you measure, then adjust, then adjust. But this patient is coming from Kabale and coming to Kampala, or coming from Eldoret, maybe to Nairobi. I'm just throwing an example. So the steps that are required may not apply to this particular patient. So you may use your expertise and say, okay, so I'm just supporting the direction you took in terms of starting the basal insulin. But yes, back to the question, SGs with this patient would certainly be of big benefit, because this patient has things that would certainly give us benefit. You started the MAs, Dr. Rose was talking about. This patient was surely a candidate who would benefit from the MA blockers. Thank you very much. Yeah? Oh, you had asked, I thought you had asked SG. Oh, is it GLP? No.
Asking, since she's overweight and GLP analogs have a better advantage, especially the cardiovascular component, So will I have started the GLP instead of the insulin and combined with the SG2 inhibitor?
Certainly, no doubt, because in terms of the weight panel, you remember the different pillars we had? In terms of weight, the GLPs are really way up in terms of efficacy, in terms of weight control. So if you're going to debate between an SG and a GLP, when you are faced with all the other benefits, the renal, cardiac, diabetes, and you have weight, and weight is really a big, like your patient had a BMI, I think it was 30, 32. So certainly the GLP would be a better. Moreover, the one which is combined would even be a better choice. But always you have to keep the cost, because your patient, I don't know how they are managing this cost. If you're going to add a statin or the MA blockers, you are adding in the GLP combined, the dual GLP and GIP, the cost should be through the roof. Your consultation to see you, so somebody has to keep the cost somewhere in the loop. But certainly the combined GLP and GIP would be a better choice. Thank you.
Dr. Moses, the Ugali thing.
Dr. Kenneth, I think, has wants to add on to this.
A quick one. Thanks, Dr. Idrissa. I'm called Luzinda from Uganda. You talked about calcium, and Dr. Barbara has also spoken about calcium. Of course, we have lots of people who fall into that category, especially menopausal women. What would be an easier, practical way of estimating calcium? DEXAs can be difficult. Serum values are difficult with comorbidities. The nephrologists sometimes assess the PTH or a vitamin D. Which one would you recommend as a quick, practical way of saying maybe someone is not too low, not too high, given all the parameters? Thanks. Calcium.
Okay, calcium. Calcium, of course, we have the usual calcium and in the blood, but of course you have to know that you have to correct it if you have situations of hypoalbuminemia. But currently we have more machines, the DEXA machines, but the cost is still high. But there's a new technology which has come where they're using a handheld scan and the kappa score. For those of you who know kappa score is sort of like the agreement between the two tests. The DEXA and that handheld scan is way high, almost 95% concordance between the two tests. So probably that will help us bring the DEXA costs down. And in the near future, I think we are going to see us moving away from the DEXA technology. Dr. Raymond.
Yeah, DEXA services are there in Kampala. Doctors Plaza, DEXA scan is at 350,000. So it's quite costly. So, but I had a question to our colleague from Nairobi, from Kenya. Giving the patient, okay, the patient had an event, cardiovascular ischemic heart disease. Yeah, using clopidogrel with atriofib, of course, and all your drugs are valid. Clopidogrel with rivaroxaban. Are you comfortable? How do you defend using these two drugs? I know they are both indicated, but how do you remain comfortable when you use these two drugs?
Okay. Before you answer, just an addition. I think I'm Dr. Musoka, I'm a cardiologist from Uganda. So in your particular patient, actually, you see when you look at the EKG, that patient had atrial fib with a very slow ventricular response, and that patient was on a beta blocker. So of course, the cardiac event that we're talking about, the MI that he suffered is not confirmed, right? So we don't have a coronary angiogram, and we are not sure that the low EF is actually secondary to ischemic heart disease. So we need to confirm that, but probably it is, given his very high risk. My comment is about when you get a patient with atrial fib and very slow ventricular response, almost regularized RR intervals, always rule out complete heart block in that patient. Many times these patients actually have a complete heart block, and you don't want to use beta blockers in those patients because you are going to drop their heart rate very low unless you have a pacemaker inserted. So always try to think about complete heart block, especially when the RR intervals are almost the same in patients with atrial fib. I think for combining, I'm just going to comment about Dr. Raymond's question, combining DOACs with P2Y12 inhibitors is actually acceptable according to the guidelines if you have concomitant comorbidities. If you have peripheral arterial disease, coronary artery disease, prior CVAs plus atrial fibrillation, then you can actually use what we call a dual therapy. And even sometimes we use triple for short times in certain types of patients. So it's actually not, you just have to weigh the risk between bleeding and ischemic risk. Thank you.
Thank you.
So, Dr. Raymond, just to add on to that, you're worried about the bleeding, right? We use the scores, you know, the usual scores which we use, including the HAS-BLED. And then also we've, unless maybe they have ulcers, we use, you'd be surprised, but we actually even use INR to see. Because you can find that the patient, maybe the platelet count is not too bad. The patient has an INR baseline of like 1.5 because of liver and also many other drugs and what. So those are some of the reasons why if you find a patient has INR, platelet count is low, has had another risk, another bleeding event, has ulcers or black stool or what, then of course you'd be more cautious and then you'd have to choose. But because you're very worried about the patient getting an MI, so, and you know, the PYPs have been proven to be protective. At the same time, the patient has to be on a NOAC because you're worried about the patient getting a stroke, which would be much worse than the bleeding, which has not yet happened. So you'd be more worried about the diseases, the complication of the disease, right, at that time, rather than the cons of using the drugs, but we do monitor them a lot. And as soon as we see maybe a bleeding in the GI or a bleeding on the stool or INR is getting high, despite it not, so, oh, by the way, I was just trying to tell you, we do use INR even if you're not on warfarin. Just remember that. We use it because it guides you. So if the INR is already high, then you know this person is at very high risk of getting a complication of bleeding, and then maybe you'd reduce the dose of the NOAC or even make sure you give it intermittently. Just remember that.
Okay, thank you very much. There's something my colleague, I think, I don't know whether anybody in the house has an answer to that. My colleague here, as we were chatting, he was asking, is it possible for us to combine an SG and a GLP agonist? Why don't you answer that question? He was actually asking the right guy. No, that will be very interesting. Yeah, but these drugs are working at different sites. So if you combine the two, you can actually combine the two, because remember, as you come down your algorithm, remember you could start with SG. It's not helping you, then you can add on a GLP. So there is no harm in having the two in the same patient. Yes, because I could use the SG entirely for a certain target, for example, HbA1c, and I'm not getting it, then I add on a GLP agonist. So there's no harm in combining the two. But of course, remember what we said, you keep an eye on so many domains. Okay, thank you very much. Okay, we can talk until the pharaohs come out of the pyramid, because the science is very beautiful and the discussion is very nice. Let's have a round of applause for our presenters, as well as the chairs of the session. Thank you very much. Now we are going to our next item, and I think at this time I would like to hand over so that you preside over
You're next.
Thank you so much, and it was very it's a pleasure to see such an interactive and an engaging session that no one wants to go out from this hall. It was such a beautiful interaction was going on. So we'll move to our next agenda. So thank you so much for the wonderful sessions and the case study presentations for today. So today we'll have a certificate presentation. So I would request Dr. Professor Edil, Mr. Sanjeeva Reddy, Mr. Pinesh will present the certificates to the Kenya doctors. So I will call one by the name. So please be here on the stage. Right. And as you know that we always surprise you with the nice gifts that you will remember us for the later period. So with the certificate you are going to get this laptop bag also. Okay. So let me call Dr. Anson Wongo from Kenya. Dr. Emily Juno. Dr. Beryl, you can come here. Dr. Charles. Dr. Isaji Ismail. Dr. Edward. Dr. Kamal Curia. Dr. Lauren. Dr. Mary Paul. Dr. Mercy, Dr. Moses, Dr. Nadia, Dr. Peter, Dr. Rosaline, thank you. And now I'll call doctors from Uganda. Dr. Asad Muinda, Dr. Anthony, Dr. Anthony. So in your laptop bag there is one box, you can keep your certificate in that. Dr. Albert, Dr. Barbara, Dr. Charles Muzoke, Dr. Dennis, Dr. Moses.
No.
Dr. Mutebi. Dr. Isra. Dr. Seka Sanu. Dr. Kenneth. Dr. Marvin Subuga. Dr. Peter Lutaya. Dr. Rose Muhindo. Dr. Raymond. Dr. Sylvester. Dr. Eugene.
Also, there is one certificate which is pending, which is one of for the special person who has contributed for this event, Dr. Ashraf. Okay, and I request ma'am also to please come on stage. Okay, so it's a thank you from all of us to Dr. Ashraf and team, Irish team, who has helped us to organize this event very nicely. Okay. Okay. So entire Irish team can join on the stage, please. Irish team, please. Mr. Mohammed, please come. Come. Also at the last, okay, at the last we want to say thank you to Dr. Adele. So there was a special gift from us for Dr. Adele also. Yeah. So I request Sanjeeva sir to please present to Dr. Adele.
Now we'll have a group photo, so I would request Kenya doctors to come here on our stage. We'll have a group photos. So please, all doctors from Kenya, please come here. First we'll have a country-wide photographs, and then we'll have a complete group photo.
All Kenya doctors, please. Dr. Nadia, Dr. Kuria, come on, please. All Kenya doctors, please come on stage.
All Kenya doctors, please come on stage. Anyone is outside?
Okay, Uganda group, please come. Uganda and Rwanda doctor, please. Uganda, Rwanda, please come on stage. Then we'll have one common group photo with Uganda and Kenya also. So I request Kenya doctors be here only. Okay, we are going to have the common photo at the last. Okay. So Uganda and Rwanda doctors, please come on stage. Kenya doctors, please be here only. We are going to have one entire group photo together. So all Kenya Uganda doctor, please last photo as a group photo. All Kenya Uganda doctors on the stage. Last photo. I know all of you are excited to go for Nile cruise. Okay. Yeah. Okay. Yeah. All Kenya Uganda Rwanda doctors, entire doctors, please come on stage.
So we'll count down. When we say one, all of us will say Ajanta way. So 3, 2, 1. Ajanta way.
Okay, so now we have to say, okay, let's unite. I will say, you have to say to reignite. Let's unite. Let's unite. Okay, so we'll take the photo. Okay.